Yeah. Yeah. Yep.
Okay. I'll swap sides.
Yep. 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 Yep.
Okay, great. With both your eyes now, if you can look at me and tell me which side's moving.
That side. That side.
And now?
Same side.
Okay. I'll check the sensation and the feeling in your face now. I'll use this cotton wool. I'll show you what it feels like on the chest.
Okay.
Just tell me if you can feel that.
Yeah. Yeah.
Does it feel the same on both sides?
Yeah.
And the same as in the middle?
Yeah. Yeah. Yeah, a little bit less on the left, I think.
Okay.
Yeah, that's fine. Yeah, again, there was a little bit less.
So less on the left than on the right?
Yeah.
Okay.
Yeah.
Okay. Can I ask you to lift your eyebrows up and screw your eyes up really tight? Don't let me open your eyes. Okay. On this side. Okay. It's okay, you can open your eyes and smile. And then let me have a look at the back of your mouth. Okay. And if you can stick your tongue out and just waggle it from side to side. That's it. That's okay. Have you noticed any difficulty with you swallowing?
No.
Okay.
No.
I'd like to have a look at your walking now. If you can just stand over by the wall. If you could just walk over to the wall for me.
Yeah.
And stop and turn round. And then on the way back, if you can walk heel to toe as if you're on a tightrope.
Oh, okay.
Okay, and just stop there. And if you stand in front of the bed and face me. And what I'd like you to do is, I am stood here in case you do fall, but if you can put both your feet together and close your eyes. And relax, okay? And you can make yourself comfortable on the bed. Can I have a feel of the pulses in your wrists?
Yep.
Thank you. Okay. I'll have a feel of the pulse in your neck and have a listen to your heart if that's okay. I'll just pass that one around there. Okay. If you can breathe in and out and hold it out. And breathe normally. And then again, in, out and hold it out. Thank you. If you lift both arms up, turn your hands over, close your eyes. Thank you, and relax. Relax your arms and let them go all loose and floppy. I'm just going to move them around. Okay, and then the other side. Okay, thank you. We'll test the strength in your arms now. If you put both your arms up, don't let me push you down. And don't let me push you down. That's it. Push me down. That's it. Push me down. Put your arms out like a boxer. If you straighten your arm, and straighten this one. That's it. Pull me towards you. That's it. Pull me towards you. And then if you can squeeze both of my hands. That's it. Let your arms go all loose and floppy again. I'm just going to check your reflexes. I'll just tap you lightly in a couple of places on your arms. Check this one. Okay. And then this side. That's okay. With your index finger, if you can touch your nose, touch my finger, touch your nose, touch my finger, on the other side. And again, one last time. If you put one hand into the palm of the other one, and with your top hand, if you turn it over and back as fast as you can. That's it. And then swap sides. Yeah, that's brilliant. I'll check the feeling again in your arms like I did on the face, but this time there's a pin that doesn't break the skin. I'll show you what it feels like in the middle first. Can you feel that?
Yeah.
And if you just turn your hands over for me, can you feel that?
Oh, yeah.
And that?
Not so much.
You can feel it, but not as much as on the right.
No.
And is the right the same as the middle?
Yeah, pretty well.
Okay. Is that the same?
No, it's definitely sharper this side.
Okay. And there and there?
Again, it's Yeah, feels a bit dull on that side.
So duller on the left.
Yeah.
The cotton wool now. Show you what it feels like again in the middle. It's there.
Okay.
It's there and there.
Yeah, it's like the face. It wasn't so much.
Less on the
Yeah,
left.
yeah.
Is the right the same as the middle?
Pretty well, yeah.
So there and there.
Yeah, a bit less on the left again. Yeah.
Similar. Less on the left.
Hardly felt that.
Okay.
On the fingers.
I'll have a look at your legs now if that's okay. Are you able to
Yeah.
just roll your
Yeah.
trousers up slightly? Just let them go all loose and floppy. I'm just going to move them from side to side. I'll check your reflexes now again in your legs.
Mm-hmm.
Again, just let them go all loose and floppy. Okay. And I'm just going to move your leg out. That's okay. On this side. Okay. I'm going to tickle the bottom of your foot. And again, we'll check the feeling in your legs. So I'll show you what this cotton wool feels like in the middle.
Yeah.
And then just above the knee there.
Yeah, definitely not as much.
And is the right the same as the middle?
Yeah, pretty well. Yeah, can't feel it as much.
So less on the left.
Yeah.
I'll do the pinprick again. I'll show you what it feels like in the middle.
Yeah, it's duller on the
That's
left again. Yeah, not as sharp.
Just
on
not
the
as sharp.
left, yeah.
Is there anything that you're concerned about?
I'm really worried about this sight getting worse.
I can understand why that must be quite worrying for you given the accident that you've had yesterday.
Mm-hmm.
My feeling is that there could be a problem with the blood vessels within the brain, and I'd like to investigate that further by doing some more investigations today, and then we can have a sit down and discuss the investigations afterwards. I'd like to do some blood tests, a heart tracing, and some imaging of the neck and the brain, if that's okay with you.
Okay, yeah.
To complete my examination, I'd like to request this patient's blood glucose and a blood pressure. Ideally, I'd complete my neurological examination with fundoscopy, vibration and joint position sense.
Can you summarise this case for me?
This 62-year-old man presented with a one-day history of persisting visual difficulties and a suggestion of left-sided neurological symptoms. This was in the setting of vascular risk factors of hypertension, type 2 diabetes and smoking. Examination revealed a left-sided homonymous hemianopia and reduced sensation throughout the left side. The remainder of the neurological examination was unremarkable. In summary, I am concerned this patient may have had a right middle cerebral artery stroke.
How did you localise the position of the lesion?
Macular sparing is usually seen in posterior cerebral artery lesions due to the supply from the middle cerebral artery. Taken with the left-sided sensory changes makes me feel the lesion is more likely, therefore, to be within the right middle cerebral artery.
In addition to your neurological examination, you also examined the heart. Can you explain why?
I felt the pulse looking for any evidence of atrial fibrillation and examined the heart looking for any evidence of valvular heart disease. I examined the carotids, purely looking for a carotid bruit that may signify carotid stenosis.
How would you manage this patient with a suspected stroke?
I'd want an urgent CT of the brain looking for any hemorrhage, and after this I'd like to admit the patient to an acute stroke unit. If, as current guidelines suggest, the patient was within current time windows for further treatment, I may wish to consider the patient for thrombolysis, providing there are no contraindications, and I may wish to consider, if further imaging suggested viable brain tissue, this patient for a thrombectomy.
Would this gentleman be a candidate for thrombolysis or thrombectomy?
Current guidelines suggest he's outside the window for these treatments, and therefore, providing there is no hemorrhage on the initial CT scan of the brain, I'd like to consider giving him high-dose aspirin.
After the initial management of the stroke, are you aware of any complications in these type of patients?
Unfortunately, stroke patients run the risk of several complications. These can range from thromboembolic disease, so I'd like to consider mechanical pneumatic compression devices for immobile patients. There's also the risk of further strokes, either hemorrhage or further ischemia. And with large strokes, there is a risk of swelling requiring craniectomies. In the acute and long-term setting, there is a risk of seizures, and these should be managed appropriately. Furthermore, patients should have their swallowing assessed by appropriate speech and language physicians, as there is a risk of deterioration in swallow function, which may lead to aspiration pneumonias. After this and over the long term, patients clearly require multidisciplinary team management, as spasticity can develop, and patients clearly require ongoing physiotherapy and sometimes medical treatment for this. Patients are at a higher risk of falls following strokes due to their reduced immobility and due to other factors like confusion and reduced cognition caused directly by the insult to the brain. Lastly, there is an increased propensity towards urinary and fecal incontinence, and this should be managed appropriately.
What are the important aspects of secondary prevention in stroke management?
Secondary prevention for stroke management firstly consists of appropriate antiplatelet agents, and current guidelines suggest the use of clopidogrel long term. After this, a patient's blood pressure should be monitored and actively treated with appropriate agents. Patients' cholesterol should be addressed, firstly with lifestyle modifications through the use of diet and advising increased consumption of fruits and vegetables, but additionally through the use of statins. Patients should be advised to cut down on salt intake, cut down on alcohol, and ideally stop smoking. Furthermore, patients' other risk factors such as diabetes should be addressed, and this should be managed as per current guidelines.
Thank you.
Thank you.
In this case, the presentation was with neurological symptoms, and the examination revealed an obvious left homonymous hemianopia and some left-sided sensory signs, with the rest of the neurological examination normal. It is important to note that cranial nerve examination may reveal pathology that does not affect the cranial nerves themselves, as here. It was established that there was a visual field defect, and this was expertly mapped by the candidate with a red hat pin. An obvious left homonymous hemianopia was demonstrated, and importantly, there was macular sparing. In posterior cerebral artery strokes, we see macular sparing due to the occipital pole receiving blood supply from the middle cerebral artery. So this complete visual field defect would be consistent with a right middle cerebral artery ischemia, assuming a vascular etiology. The combination of the visual defect together with the left-sided sensory signs confirm the right hemisphere cortical damage of a right middle cerebral artery stroke. The candidate decided to first examine the cranial nerves as the patient was sitting opposite him, and then he tested gait and for Romberg sign, and then continued the examination on the bed to include a focused cardiological and neurological examination. Checking for atrial fibrillation and listening for valvular pathology and a carotid bruit is important. There is a lot to examine here, but it must be remembered the candidate can abbreviate the full examination sequences, as there will not be enough time to cover all areas as would normally be done in individual PACES stations. The candidate did not perform fundoscopy, as acuity was normal, and the very clear visual field defect that respected the midline did not represent an actual eye problem. One of the skills of the clinical consultation station in PACES is deciding what are the important areas to focus on. The combination of the history and very obvious physical findings should make this case relatively straightforward, and a good candidate should be able to state that the lesion is localized to the right hemisphere. The relatively acute history, together with the vascular risk factors, is strongly suggestive of an ischemic etiology. In conclusion, it is reasonable to suggest that this gentleman has a partial right middle cerebral artery stroke, being partial as there is absence of any obvious left-sided upper motor neuron signs, namely weakness, increased tone, and hyperreflexia. There is a differential diagnosis, as other lesions of the right hemisphere may produce similar findings, but an ischemic etiology would certainly be top of the list here. The conclusion of the station as here included an explanation to the patient of what is the likely cause of his symptoms and a plan for investigations and potential treatments. The end of the examination would finish by suggesting checking for the blood pressure and a BM for blood glucose to the examiner.
Hello there. Is it Sarah Jane?
Yeah.
My name's Dr. Gavin Britton. I'm one of the medical doctors in clinic today. Your GP's asked me to have a chat with you about your vision, is that right?
Yeah.
Can I start by asking how old you are?
Yeah, I'm 33.
And can you tell me a bit more about what's been going on?
Yeah, I've just noticed I've just been struggling recently with my vision. Yeah. That's it really. That's where I've gone.
And how long has this been going over?
It's hard to say. I'm not sure. Like quite a while now. Yeah.
Okay. Do you think your vision was normal months or years ago, or?
It's probably about the last year. Yeah. So, over the last year, I've noticed it more.
And is there any periods where your vision's normal?
Yeah, it's not all the time. It's definitely worse at night.
Okay.
I feel like I just can't go out like driving at night and things anymore. It's definitely worse in the dark. But yeah, I'd say that's so. In the day, I don't notice it as much.
Okay, fine. And do you think this is getting worse over time, or is it staying?
Yeah, it definitely feels like it's worse. That's what's made me come. It's been feeling like it's getting worse.
Okay. And just to ask some more specific questions, have you noticed that you can't see to one side, the left or right, or top and bottom?
No.
That seems okay.
Yeah.
Have you noticed any problems with your ability to read a book or a newspaper?
No.
Or to see into the distance? So when you're driving, can you still see the licence plates?
Yeah, just not at night.
Just not at night?
Yeah.
Okay. Have you noticed any flashes within your vision, or zigzag lines, for instance?
No.
Or sparkling lights?
No.
Okay. Ever get any blackening of the vision where you just can't see completely?
No. It's like I say, it's just this sort of blurry thing, and in the dark, I'm noticing it more.
Okay. Do you ever get pain within the eye or grittiness?
No.
Okay. And can your eye problems ever be associated with a headache, or do you suffer from them?
Not really. I mean, I get headaches, but not necessarily to do with my eyes. You know, they're not linked.
Okay, fine. Okay. Is there anything else you've noticed at the minute?
No. Like I say, it's just this that's been bothering me.
And this is bothering you for, let's say, the last year or so. Prior to that, how was your eyesight?
Yeah, good. Yeah,
Okay.
had no problems.
You never had any episodes of reduced eyesight in the past?
No.
That you've been aware of? Okay. And ever had any episodes of arm, leg or face weakness?
No.
Or changes in sensation?
No.
Okay, fine. I'd just like to ask a bit more about your background, if that's okay. Do you have any medical problems?
No, not that I know of.
Okay. Nothing you've been diagnosed with? No. Okay. Do you take any medications?
I mean, I've got a bit of hay fever, I'll take like antihistamine or I'll have paracetamol. I don't have anything that I'm on.
You don't regular medication?
Yeah.
Okay. Do you take anything over the counter?
Just that sort
Just
of thing,
those?
yeah.
You don't take any herbal remedies or vitamins?
I'll go through stages, I suppose, where I'll take some vitamins for a bit and then, but
Okay.
nothing specific.
Are you taking any at the minute, or?
No.
Okay. Do you have any allergies?
A bit of hay fever and
just
just
anything to medication?
no.
Okay. Just a bit about your home life, if I can. Who do you live with?
Just my husband.
Do you have any children?
No.
And do you work?
Yeah.
What do you do?
Just in a supermarket.
Okay.
Cashier, yeah.
And has this affected your job in any way?
I mean, obviously, the thing I'm worried about right now, I can see I'm there, I'm working. Obviously, if I'm on the tills or pricing up or anything like that. But my worry is this thing that's happening. If it's suddenly got worse at night, is it going to happen in the day? Am I going to start struggling there? And I'm just conscious of it, really.
Yeah, I can understand that must be quite concerning for you. We'll touch on that at the end, and hopefully we can try and reassure you a bit or come to a conclusion if that's okay.
Yeah.
Do you smoke?
No.
Have you ever smoked?
No.
Do you drink alcohol?
I drink not every day or anything. Just.
How much would you drink in a typical week?
Well, sometimes I wouldn't necessarily drink, and then
Okay.
sometimes I might drink at the weekend or something. But yeah, I don't drink every
Okay.
night or anything.
Fine. Is there anything that runs in the family? Any problems with the eyes or brain?
Well, not that I know of, but I'm adopted, so.
Okay, fine. So we're not sure. Okay, that's okay. Just to come back to some more specific questions now. Have you noticed any changes with your weight
No.
or appetite?
No.
Any changes with your bowels
No.
or bladder function? Any changes with joint pains or any rashes?
No.
Any coughs or colds
No.
or feeling unwell currently in any way? Any fevers or night sweats?
No.
Chest pain or breathlessness?
No.
Okay, fine. What I'd like to do now is start by having a look at your eyesight and a look at the rest of the nerves in your face, if that's okay.
Yeah.
Have you noticed if your problems are to do with one eye or the other or both?
Just the same, I think.
Okay. Have you been to the opticians and had your eyes tested recently?
No, I don't like going, to be honest.
Okay. I'm going to check your vision now, if that's okay.
Yeah.
Do you normally wear glasses or contact lenses?
I've got contact lenses in.
Okay. If you could cover one eye for me and read from the top down.
TVH XUA HTYO. It's a bit out of focus then, yeah.
Okay. So that's 618. So if you can try the other eye now.
TVH XUA HTYO.
Okay.
Same, yeah.
And the same again, you can't see any more.
It's a bit blurry, yeah.
Okay, that's fine. If you can look at the wall straight behind me, I'm just going to shine a light in your eyes. Okay, and then look at the wall behind me and look at my finger. Okay, I'll have a look at the backs of your eyes now. I'll need to come slightly close to you, but if you keep looking at a spot on the wall behind me, and just blink as normal. And if you look at the light, thank you. I'll just have a look at the other side. If you look at the light, thank you. So if you can look at me and tell me which hand's moving.
Left, right, both. Both.
Okay, and cover one eye. So I'll cover the same eye, and I'd like you to look directly into my eye, and then tell me, just say yes when you can see this red pin.
Yes. Yep. Yep. Yeah. Yep. Yep. Yes. Yep.
I'll swap sides, you stay as you are.
Yes. Yes. Yep. 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 Yeah. Yes.
Okay, and swap sides to me. Just do the same side.
Yes. Yep. 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 Yes. 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 Yes.
Okay, great. Have a look at the movement of your eyes now. Have you ever noticed that you've had any double vision or blurry vision?
Just what I've said, not just to like blurry it in the dark and things.
You don't see two instead of one? Or...
No, it's not double.
So if you have a look at my finger and just follow it with your eyes, but keep your head still. Let me know if you get any double vision. Can I ask, have you ever noticed any change in your sense of smell?
No.
Or your ability to do tasks with your hands, such as turning a key or picking up objects like a pen?
No.
Yeah. Okay. And how's your hearing?
Fine, I think, yeah.
Okay. Am I alright to just test that?
Yeah.
If you could just cover one ear for me, and just tell me if you can hear this.
Yeah.
Okay. And the other side.
Yeah.
Great. What I'd like to do now is just have a quick look at your walking, and then we'll have a seat on the bed. If you can walk towards the wall for me. And then just stop and turn around. And if you can walk back heel to toe as if you're on a tightrope. That's fine, you can stop there. And if you just turn to face me, I am here to catch you if need be, but if you just put your legs together and close your eyes. Thank you. And just have a seat on the bed. If you could put your arms up, turn your hands over and close your eyes. And relax. And just let your arms go all loose and floppy. I'm going to move them about now. On the other side. Okay. I'll check the strength in your arms now. If you can put both your arms up, don't let me push you down. On the other side. And if you push me down, push me down on this side. If you put your arms out, straighten your arm for me, and straighten this one. That's it. And bend your arm towards yourself. That's it. Bend your arm towards yourself. That's it. And if you can grip my hands with both of yours and squeeze as tight as possible. Thank you. I'll check your reflexes now. So if you just let your arms go all loose and floppy, I'm just going to tap them. That's okay. And then the other side. Okay. And the other side. I'll just borrow that arm again. Thank you. With your index finger, if you could touch your nose and touch my finger, and touch your nose, back to my finger, and then the other side. Yeah, and back again. That's great. If you can put one hand into the palm of the other, and with your top hand, if you turn it over, turn it back, and go as fast as you can. That's great. And then the other side, so as fast as you can. Great. Thank you. I'm going to check the feeling in your arms now. First off, I'll use this pin. It doesn't break the skin, but I'll show you what it feels like in the middle there. Can you feel that?
Yep.
If you just turn your hands over for me, and just tell me if you can feel that.
Yep.
You feel that on both sides?
Yeah.
Does it feel the same on both sides?
Yeah.
Does it feel the same as in the middle?
Yeah.
Just tell me if it changes as we go up.
No.
Stays the same.
Same.
Okay, good. I'll just do the same thing but with this cotton wool. I'll show you what it feels like in the middle. Can you feel that?
Yep.
Can you feel it there?
Yeah.
And there? Does it feel the same as in the middle?
Yeah.
Does it change as we go up?
No.
Does it change as we go up?
No.
Good. Okay. We'll move on to look at your legs now. Are you able to pull up your trousers at all, just to above the knee? Thank you. I'm just going to move them from side to side, just let them go all loose and floppy. And I'll move your ankles. That's fine. That's okay. I'm going to check the strength in your legs now. If you can lift this leg off the bed for me. That's it. And this one. And then push down towards the bed. That's it. Push down towards the bed. If you can bend your leg at the knee. And if you can kick out for me. That's it. And if you can pull in towards your bottom. That's it. And then this side, if you kick out and pull in towards your bottom. That's great. Push down as if you're pushing on a car pedal. And this side. And if you lift back towards your head, the opposite way. That's it. And this side. And then big toe back towards your head. Big toe back. That's great. That's okay. I'll check your reflexes again. Let your legs go all loose and floppy again. Okay. I'm just going to move this leg out now. That's okay. I'm just going to tickle the bottom of your foot. And we'll check the feeling in your legs again. So I'll show you what this cotton wool feels like in the middle again.
Yep.
And can you feel that?
Yeah.
Does it feel the same on both sides?
Yep.
And the same as in the middle?
Yep.
Good.
Same.
It feels the same?
Same.
Good. And then the pin, I'll show you again what it feels like in the middle. Feels the same?
Yeah.
Good. And can you feel that?
Same.
Same all the way up?
Same.
Same all the way up. Okay. If you could put your heel onto your knee and then slide your heel down your shin towards your ankle, lift it off and put it back to your knee, and then just do that again and swap sides. So this heel onto that knee and slide it down, lift it off and back to the knee and slide it down. Great. Thank you very much. You mentioned at the start that you were concerned about your eyesight in work. Based on the appearances at the back of your eye, you may have a condition called retinitis pigmentosa, and I'd like to refer you to an ophthalmologist to discuss this further. I'll provide you with an information leaflet in the meantime. Do you have any further questions?
No.
Thank you. To complete my examination, I'd like to request this patient's blood glucose.
Please could you summarise this case for me?
This young female presented with progressive visual difficulty, mainly at night. Examination revealed reduced visual acuity bilaterally, however fields were normal. Fundoscopy revealed a waxy pallor of the optic disc, and there was pigmentation of the retina in a bone spicule pattern. There were no other focal neurological signs, and importantly, there were no cerebellar signs, and there were no features of a peripheral neuropathy. In summary, I think this patient has retinitis pigmentosa.
How is this problem affecting the patient?
Currently, this is affecting her vision at night, especially when driving. It sounds like she's managing her activities of daily living and is continuing to work. However, I'd be mindful that this may well be impacted in the future.
Are there any other differential diagnoses of bilateral visual loss that you're aware of?
Transient bilateral visual failure can be caused by migraines. However, permanent bilateral visual loss, as in this case, is more classically caused by other conditions such as glaucoma, cataracts, diabetic retinopathy and maculopathy. However, these were not evident during the examination or the history today. Other causes which may be more relevant to this patient's age, however not consistent with the body habitus or the history, may be papilledema, which could be seen in the setting of idiopathic intracranial hypertension. Rarer causes include Leber's optic neuropathy, and increasingly rare causes of optic neuropathies can be metabolic or toxic.
If this lady was confirmed to have retinitis pigmentosa, how would she be managed?
So after confirmation through an ophthalmologic review, I would wish this patient to be referred to a geneticist for genetic counselling, and they may wish to perform genetic studies thereafter. Unfortunately, there are no current treatments for retinitis pigmentosa, and the remainder of the management is largely supportive. I would like to signpost this patient to appropriate charities and ensure that she receives appropriate occupational therapy in the form of visual aids.
You demonstrated this lady already had some evidence of visual impairments. What's the likely prognosis here?
Retinitis pigmentosa is a progressive condition, and usually by the time patients are middle-aged, most patients meet the legal criteria for being registered blind.
This lady was adopted, so we didn't ascertain any family history. But do you know the inheritance associated with retinitis pigmentosa?
Retinitis pigmentosa can be inherited in an autosomal dominant, autosomal recessive, or X-linked pattern. Approximately 30% of cases are due to de novo mutations.
Do you know of any conditions that are associated with retinitis pigmentosa?
There's several conditions which can be associated, and these include Bardet-Biedl syndrome, Usher's syndrome, Alström syndrome, Refsum syndrome, and Kearns-Sayre syndrome.
Are you aware of any features that may suggest a syndromic diagnosis of retinitis pigmentosa?
Usher's syndrome is the association of retinitis pigmentosa and sensorineural deafness. Refsum syndrome, for example, is the association of retinitis pigmentosa and progressive muscle wasting and weakness, and ataxia, which is usually seen in later life.
Are you aware of any implications for this patient regarding driving?
So this patient would need to inform the DVLA of her diagnosis. The DVLA provide quite strict guidelines regarding patients' best corrected visual acuity and also regarding any visual field loss which may impair their driving.
If the patient's vision was significantly impaired and you were aware that she hadn't informed the DVLA, what would you do?
If the patient didn't inform the DVLA and continued to drive, I may wish to revisit this with the patient, provide further explanation, and may well wish to involve other health professionals such as the patient's general practitioner to explore the patient's concerns and try and implore them to stop driving and inform the DVLA of their diagnosis. Ultimately, if the patient declined to do this, I would need to break patient confidentiality and inform the DVLA of the underlying diagnosis due to potential safety of the general public.
Thank you.
Thank you.
The presentation of bilateral visual disturbance has a wide differential diagnosis, and in this case the patient complained mainly of her vision being affected at night. Nighttime visual problems can be due to simple nearsightedness, cataracts, vitamin A deficiency, or as in this case, a genetic condition such as retinitis pigmentosa. Diabetes should always be a consideration in a patient with visual problems. Her young age makes cataracts unlikely, although be aware they can occur prematurely in diabetics or in patients with chronic steroid usage. Macular degeneration would be very unlikely in such a young patient. Vitamin A deficiency would be rare, but possible in pancreatic insufficiency or patients with cystic fibrosis. The candidate here examined cranial nerves initially, including visual acuity, and then went on to fundoscopy, as there were no obvious initial abnormalities, except reduced visual acuity. Once fundoscopy was performed, hopefully the diagnosis will become clear. Differential diagnosis of the changes seen could include diabetic retinal changes, laser treatment scars, or even infections such as toxoplasmosis or rubella, but hopefully the changes seen will be more in keeping with retinitis pigmentosa. Retinitis pigmentosa can occur in isolation or may be associated with some rare syndromes. The candidate quite rightly chose to examine the neurological system after asking the patient to walk. Cerebellar signs or peripheral neuropathy signs would be the main areas to be assessed, as abnormalities would suggest the possibility of one of the more rare syndromes. Retinitis pigmentosa causes gradual progressive visual loss due to build-up of pigment within the retina, and classically patients present with night visual disturbance initially, then decreased peripheral vision resulting in tunnel vision. Complete blindness is uncommon. There is no cure for retinitis pigmentosa, and referral to an ophthalmologist was suggested by the candidate, and support services were also mentioned. Genetic counselling was discussed during the questioning, as this is a genetic disorder. The patient's concerns regarding her vision were addressed adequately, and a clear management plan agreed going forward.
Good morning.
Good morning.
My name's Dr. Farrant. Can I confirm your name, please?
Yeah, my name is Nathan Stocker.
Nice to meet you, Nathan. What is it you come to see me about today?
I've just come to see you about a bit of knee pain that I've been having for the last couple of weeks.
Okay. Tell me a bit more about the pain.
Well, it came on, like I say, a couple of weeks ago, but it doesn't seem to be getting any better.
Okay. And whereabouts in the knee is the pain?
It's mostly around sort of the upper portion, just above the cap.
Right. Okay. And how is it affecting you?
Well, I'm a very active person, like in my personal life, so it's been getting in the way of that. Just making day-to-day life more difficult, basically.
Okay. What sort of things is it stopping you from doing?
Well, the commute to work is really difficult with it. Obviously, I get the train, so there's a lot of walking and stuff involved with that, and obviously I can't train as much anymore either.
Right. Okay. And so you said the pain's on the top of the knee. Have you had any swelling associated with the pain?
A little bit, yeah. It kind of like it's better and worse at certain times.
Okay.
So
That's fine. And have you noticed any sort of redness, or is the knee getting hot at all?
not really. No, it does get a bit hot sometimes.
Okay.
But
Fine. And is it limiting the amount you can bend and sort of flex the knee, or?
yeah, definitely. Yeah,
Okay.
it's
And what about stiffness? You're waking up in the morning finding that the joint's really stiff, difficult to move and stuff like that?
yeah. Morning, it tends to be a bit of an uphill battle in the morning. But as the day goes on, it doesn't go as stiff, but I'm still in a lot of pain.
Okay. And how about, have you sort of noticed the knee locking at all?
Certain movements, I feel, make it lock.
Make it a bit
yeah.
more difficult. Okay. And then, so say when you're walking and you're on your way to work, have you sort of noticed that you feel as though the knee's about to give way at any point or buckle in?
Yeah, a little bit. Yeah.
Okay. Fine. And it's clearly it's been something that's been quite painful. Have you been taking any sort of medications just to try and help with that, or?
Just ibuprofen and paracetamol, basically.
Okay. And you said it's been going on for about 2 weeks.
Yeah, about 2 weeks.
Has it been getting worse during that time, or about the same? Or?
It's gotten worse. Yeah, I feel it has.
Fine. So pain's been going for 2 weeks. Had you had any trauma to the knee sort of before this pain came on, or?
No trauma. No, I mean, like I say, I train a lot, so
Okay. And how's your health been in general? Have you been unwell sort of in the last couple of weeks or so, or?
Oh, a couple of weeks prior, I was a bit ill with a stomach bug.
Okay.
But whether they're related or not, I don't know.
Was it sort of diarrhea was the main problem?
Yeah, diarrhea. Yeah, and a bit of vomiting here and there as well.
Okay. And how many times a day were you opening your bowels, do you think?
How long's a piece of string? A fair amount, yeah.
Okay, so sort of 7-8 times a day, something like that.
Yeah, give or take, yeah.
Okay. And then, did you notice any blood in the stool at all?
Not that I can think of. No,
Okay.
It was mainly just bile here
Sort
and there.
of, like really watery type stuff?
Yeah.
Okay. And then vomiting, sort of any blood in the vomit that you noticed, or?
No, not in the vomit, no.
Okay, good. And how did it affect your appetite?
Well, obviously, when you're ill, you don't really want to eat
Mm-hmm.
because you feel you're just kind of adding more to it, sort of thing. So, yeah, my appetite was just down the drain. Yeah.
Okay. And did you lose any weight during that time?
Yeah.
How much weight did you lose?
Maybe about a stone.
Stone and
something
weight.
like that, yeah.
Okay. Fine. So that's it's a significant amount of weight loss. Fine. And with the diarrhea, was it sort of worse in the daytime, worse at night time?
I'd say more in the daytime.
Daytime.
I still had it at night, but it wasn't as often.
Fine.
If that makes sense.
And it wasn't sort of waking you during the middle of the night to open your bowels, was it?
No.
Okay. Fine. And then just a few more sort of general questions. Any headaches with any of this at all?
Yeah, I got a couple of headaches here and there, but I don't think they were related, to be fair.
Okay. Any visual changes?
Sort of, yeah, a little bit.
So what, like pains in your eyes,
Yeah,
or double
yeah.
vision? Pains in the eyes.
Pain, yeah, eye
Okay.
pain, yeah.
Fine. Did you notice any redness in the eyes or?
Yeah, well, I did get like it felt like almost like conjunctivitis, maybe. I don't know.
Right. Okay. Fine. Okay. So what I'll do is when we examine you, I'll have a look at your eyes as well.
Yeah.
Sore throat.
No, not really.
Okay.
No.
What about breathing? Any sort of coughs, shortness of breath, anything like that?
No, nothing like that.
Good. What about chest pains, palpitations, anything?
No, nothing that I can
Nothing you can
think of. No.
Okay. Good. And then anything that you see your doctor for on a regular basis? Any sort of medical problems that I need to know about?
No, not really. It's just sort of been the past couple months. It's just
Things have
yeah.
gotten worse.
Yeah.
Okay. And then, are you on any regular medication?
No.
Good. Are you allergic to anything?
No.
Do you smoke?
I probably smoke maybe 10 a day, maybe
And-
more, maybe less.
And how long have you smoked for?
Since I was 16.
Okay. And
Yeah.
how old are you now?
I'm 27 now.
27. So 11 years.
Yeah.
Okay. You know, aside from what you've come with today, it's really important that you do try and cut down on the smoking, stopping completely if possible, because that's going to be something that's going to be beneficial for your health going forward. All right. Do you drink any alcohol?
I drink socially, like weekends when I see my friends. That's about it.
Okay.
Yeah.
And do you drink a sort of a significant amount when you drink socially, or just a couple of pints? Or?
We have a binge drink.
Okay.
Yeah.
Fine. And is there any family history of any medical problems?
I know my dad suffers from psoriasis.
Mm.
Yeah, he really kind of.
Okay. Have you noticed any rashes or sort of skin changes or anything like that?
No, sometimes I get like a bit of an itching here and there, but I don't
Okay.
know if that's.
Fine.
But I just put a bit of ointment on and that's done.
Okay. Fine. Well, I'll have a quick look at your skin as well.
Yeah.
So what I would say is I think you've done absolutely the right thing in coming to see me today. Okay. Clearly this is something that's concerning you because it's affecting your commute to work and affecting your personal life. So what we need to do now is I need to have an examination of your knee. I'll have an examination of your abdomen as well, given the pains that you've been getting and the diarrhoea that you had. And then I'll have another chat to you about where we're going to go next after that. All right?
Yeah, thank you.
Thank you. First thing what I'd like you to do is just get up and walk up and down for me, and then we'll get you on the bed and I'll examine you. Okay? Yeah. Okay, so if you could just start walking for me, please. And turn around for me. And back to the wall. Okay, we'll get you on the couch now, all right? Okay, just take a nice deep breath in for me, please. And out. Okay. Just going to have a look at your knee first, all right? You said it was along the top there that it's tender. Okay, and just bend the knee for me now. Okay. Was that painful to bend it?
Yeah.
Just a little bit. And straighten it out. Okay, now let me just do all the movements, alright? So just let your knee go nice and floppy for me, alright? It's a bit tender when we bend it all the way up like that. Okay. Okay, just relax now. Okay. Okay, fine. Just bend that other knee for me as well. Straighten it out. So that's not as painful, that one, is it, at all? That's all right. There's good movement in that one too. Okay. Can I have a look at your hands now, please? And turn them over for me. And back over. That's great. Rest that hand down. Okay. Can you just pull down your eyelid for me, please? And look up to the ceiling for me if you would. Okay, and just look down to the floor. Okay, that's great. Open your mouth for me now. And lift your tongue for me. Perfect. Okay, and just relax. Okay, I'm just going to have a quick feel of your neck now. In fact, could you sit forward for me?
Yeah.
Okay, I'm just going to lie you down flat now, all right?
Yeah.
Just going to have a look at your abdomen now, okay? You got any pain in your abdomen at the moment?
No, this current moment. So.
Okay, good. Okay, nice deep breath in for me, please. And out. And again. 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 And out. Okay. Just roll towards me slightly if you would. And back down. You want to just roll the other way for me slightly and back down. Okay. Okay. Just going to have a look at your legs now, all right? First of all, what I think we need to do is do some more tests, all right? We need to get an x-ray of your knee to look to see if you have actually damaged your knee, if you've got any breaks in there, or if there's any sort of problems with the cartilage. And then what we need to do is do some general blood tests, all right? So that'll be some blood tests to look for signs of infection, blood tests to make sure that your salt levels are all right, and also blood tests just to check that your liver's okay, all right? I definitely think you've done the right thing in coming to see me today, because this is something that clearly needs a bit more investigation, so thank you for coming in. All right.
So what do you think it is then?
At the moment, it's difficult to say, all right? It could be that this is just simple wear and tear in the knee, and that the sort of the tummy bug that you had was just that, a tummy bug. Or it could be that the two things are linked and one has caused the other one. But at the moment, it's a bit too early to say, and I think it's important that we get these further tests done so that we can then establish sort of and get a better idea about where we're going to go next. All right?
Yeah.
Thank you. So to complete my examination, I would like to take a full sexual history from the patient. I would like to examine the external genitalia to look for signs of a sexually transmitted infection and perform a digital rectal examination with a chaperone present.
Can you present your findings back to me, please?
So I believe this patient firstly has a reactive arthritis. The positive clinical findings that have led me to this diagnosis are that he has a left-sided painful knee, which has that's positive for crepitus, but a good range of movement. He also reports significant stiffness, particularly in the mornings. There's no effusion in the knee, and it's not hot or swollen at the moment. Also, prior to the development of this painful knee, he had a diarrheal type illness, which makes me think that in particular this could be a reactive arthritis.
Okay. Have you got any other differentials?
So other potential differentials for this condition would be early onset of rheumatoid arthritis. It could be a septic arthritis, or it could be that the gentleman simply has a musculoskeletal injury to his knee.
Okay. How about gonococcal infection?
So it could be a gonococcal infection, which gonococcal infections would more likely cause a septic arthritis as opposed to a reactive arthritis, but it is possible in this case. One thing I should add is that in this case, this gentleman appears to have had the trigger for the reactive arthritis is the diarrheal type illness, but other potential triggers for a reactive arthritis would be sexually transmitted infections, in particular chlamydia.
Okay, fine. What's the treatment and prognosis then?
So, treatment for a reactive arthritis would be through, firstly, supportive measures, so ensuring that the patient has adequate analgesia, and then treating the underlying condition or the underlying cause of the reactive arthritis. So, if there's evidence of a sexually transmitted infection, patients would need treatment with antibiotics, though in this case it appears more to be a diarrheal type illness or a gastroenteritis, so the treatment would be supportive through rehydration.
Okay. Are there any investigations in particular you'd want to conduct then?
So for this gentleman, investigations that I would like to do would be, firstly, I'd like to do an X-ray of the knee to look for any evidence of fracture, any evidence of signs of arthritis or early onset arthritis. Also, I'd want to do an X-ray of the joints above and below the knee to see if there's any pain radiating from those joints. I'd also want to do some blood tests. So in general, I'd like to do full blood count, urine electrolytes, CRP and the liver function tests, looking for signs of infection or also signs of liver dysfunction as a result of the diarrheal type illness. In particular, we'd also like to do check a patient's rheumatoid factor to make sure this isn't an early onset rheumatoid arthritis. I would also, in this case, like to do a stool culture, given that the gentleman's had a diarrheal illness. And even though there wasn't any obvious effusion, I would still like to try and aspirate this patient's joint, because if there's any evidence of septic arthritis, that is a clinical emergency and that would need urgent treatment, or to make sure there's no evidence of a crystal arthropathy, in such as a gout or a pseudo-gout, which could be presenting in this case.
Okay. So let's go back to your diagnosis of a reactive arthritis.
Mm-hmm.
Can you think of any genetic links that are there?
So reactive arthritis is associated with the HLA-B27 gene. This gene is widely associated with a larger group of conditions known as the seronegative spondyloarthropathies, of which reactive arthritis is one. Others are enteric arthritis, psoriatic arthritis, and ankylosing spondylitis.
And what do you think the relevance is here then?
So this gentleman mentioned that his father suffers with psoriasis. Therefore, I think there's a high likelihood that he and both him and his father have the HLA-B27 gene.
Okay, thank you very much.
Thank you.
This gentleman has a classic history of reactive arthritis. He has symptoms of asymmetrical oligoarthritis preceded by a diarrheal illness. Differential diagnoses include rheumatoid arthritis, reactive arthritis or other spondyloarthritis, especially with his family history of psoriasis, and also gout. Less likely is a meniscal lesion or septic arthritis. Good candidates will know that gonococcus causes septic arthritis, and so the patients typically present with purulent urethral discharge and concurrent joint pain and also fever, while chlamydia, salmonella and campylobacter are also classic causes of reactive arthritis. The joint symptoms usually postdate the initial infection by some weeks, typically 4 to 8. Candidates should examine the patient, specifically examining the knees and ankles to assess for the presence of a hot, swollen joint, plus any effusion. The joint examination should include inspection, palpation, and an assessment of range of movement. Appropriate investigations: bloods for urate, CRP, ESR, white blood cells, rheumatoid factor, and CCB antibodies. Consider HLA-B27, which is positive in up to 50% of patients with reactive arthritis. If there's any suspicions of an STI, then urine and genital swab testing for gonorrhea and chlamydia in particular would be indicated. There are no specific findings on a plain radiograph that can establish a diagnosis of reactive arthritis. If there was any effusion, then joint aspiration would be appropriate for cytology, crystals, CNS. Rheumatology referral is appropriate here. Acute management of reactive arthritis would be with simple analgesics, including non-steroidal anti-inflammatory drugs, unless contraindicated. The condition is usually self-limiting, and most patients will not require steroids or disease-modifying anti-rheumatic drugs to control the inflammation or to prevent erosive joint changes.
Good afternoon.
Hi,
My name's Dr. Farrant. Can I just confirm your name, please?
it's Jane.
Nice to meet you, Jane. So what is it you've come to see me about today?
I've just not been feeling myself recently. Just various sort of vague symptoms, so I was wondering if you could help with that.
Okay, sure. So when you say vague symptoms, just tell me a bit more about what you mean.
Either not sleeping or sleeping too much, either putting on weight or dropping it when I shouldn't really be. Just difficulty concentrating, balance, my voice is sometimes a little bit hoarse. Just nothing really that stands out, but just things are sort of starting to add up and it's starting to affect my life on a day-to-day basis.
Okay. So quite a lot of different things that you've mentioned there. I'll try and work through them all steadily. So first of all, you said sort of weight loss and then weight gain. So over what sort of time period are we looking?
Oh, several months, so it's like a period of, say, 4 months that have dropped a bit, and then like over the next 3 months I've put it on, but too quickly, and I don't think I'm eating that much that would warrant that amount of weight gain. So.
Okay. And how much weight gain are we talking about?
Well, dropping sort of under a stone, but can be swinging the other way about 1.5 stones.
Right, okay, so quite a significant amount of
yeah.
weight change. Okay. And you said your appetite hasn't really changed during those periods of time?
Not really, no. No, I wouldn't say I feel anything different to normal, so yeah.
Okay. And do you eat a healthy diet or?
Fairly. I mean, I'm not very healthy, but equally I wouldn't class myself as being very unhealthy.
The recording has stopped. This meeting is being recorded.
Good afternoon.
Hi,
My name's Dr. Farrant. Can I just confirm your name, please?
it's Jane.
Nice to meet you, Jane. So what is it you've come to see me about today?
I've just not been feeling myself recently. Just various sort of vague symptoms, so I was wondering if you could help with that.
Okay, sure. So when you say vague symptoms, just tell me a bit more about what you mean.
either not sleeping or sleeping too much, either putting on weight or dropping it when I shouldn't really be. Just difficulty concentrating, balance. My voice is sometimes a little bit hoarse. Just nothing really that stands out, but just things are sort of starting to add up, and it's starting to affect my life on a day-to-day basis.
Okay. So quite a lot of different things that you've mentioned there. I'll try and work through them all steadily. So first of all, you said sort of weight loss and then weight gain. So over what sort of time period are we looking?
Oh, several months. So it's like a period of, say, 4 months that have dropped a bit, and then like over the next 3 months I've put it on, but too quickly, and I don't think I'm eating that much that would warrant that amount of weight gain. So.
Okay. And how much weight gain are we talking about?
Well, dropping sort of under a stone, but can be swinging the other way about 1.5 stones.
Right, okay, so quite a significant amount of weight change. Okay. And you said your appetite hasn't really changed during those periods of time?
Not really, no. No, I wouldn't say I feel anything different to normal, so yeah.
Okay. And do you eat a healthy diet or?
Fairly. I mean, I'm not very healthy, but equally I wouldn't class myself as being very unhealthy.
Okay. And you said there were some problems with sleeping.
Yeah, I can either sleep 2 to 3 hours a night, so insomnia, or completely the opposite way, about 15 hours. So,
right.
And even then, I don't feel like I've had a proper night's sleep. So.
Right. And sort of when it's the not sleeping for very long, is it getting to sleep that's the problem, or waking up too soon?
Getting to sleep, yeah.
Right. Okay. And like with the weight loss and change, that's over a period of sort of a couple of months where you're losing weight and then a couple of months where you're gaining weight. Is it the same with the sleep?
It seems to be weight loss, lack of sleep, weight gain, more sleep. So it seems to be in that sort of cycle now that you've mentioned it. I've not really put them together, but yeah.
Okay. And so you mentioned some other problems as well. One was vision, was that a problem, or?
Yeah, I'm finding it difficult to read an awful lot of text, just blurry vision really, and actually a little bit dizziness as well. So.
Okay. So what brings the dizziness on?
I'm not sure really, just comes and goes. So if I'm more tired, then that's when I notice it more.
Okay. And does it happen when you sat down, when you stood up?
Stood up, really. Walking, bending, and then standing back up again. Doing a lot of movement.
Okay. So if you stood up now, do you think you would start to get dizzy?
Probably, yeah.
Okay. But it doesn't happen when you sat down?
I guess it's there, but it's not really a problem, so.
Okay. And have you ever blacked out with the dizziness?
I have done, yeah. But I'm not sure actually if it's dizziness related or just feeling faint from, standing up and feeling faint, so.
Okay. And any other problems that you've sort of noticed?
Not really, no. I think they're the main ones, really, yeah.
Okay. And you said it's sort of affecting your sort of day-to-day life. In what ways is that affecting things?
Just cognition, so I'm finding my job harder to keep at, just tiredness and being able to concentrate, and also dizziness as well. And I'm trying to keep like a routine, good healthy diet and sleep pattern, but it's not really seems to be working. And just finding things harder and harder, to be honest, and slightly concerned.
Yeah, that must be really difficult for you. Sort of, what job is it that you do?
I'm a civil servant, so mainly desk-based with a little bit of travelling around.
Okay. And I can imagine, if you're getting dizzy quite a lot and tiredness is a real issue, then actually being able to focus and concentrate during your job, that must make life quite tough.
Yeah.
Okay, fine. And, clearly this has been going on for a while, but when do you think all of this started?
Recently, probably the last sort of 8 to 10 months, sort of gradually getting worse and worse. So I've been to see a couple of other doctors, but nothing's really come of it. But things are progressively getting worse, so I need to really sort of address them.
Yeah.
So
clearly there's an issue and we need to get to the bottom of it. So just a few other sort of more general questions. Any headaches at all?
Yeah, actually, yeah.
Okay. Breathing problems?
Not really, no, I've not noticed anything.
Okay. Chest pains?
No.
Palpitations?
Yes, I can sort of feel things are getting a little bit.
Okay. And then any nausea or vomiting at all?
No,
Constipation, diarrhea?
no,
And any problems with your urinary system?
no.
And then any sort of muscle weakness at all that you've noticed?
Yeah, I've noticed.
Okay.
I've been trying to do a little bit of fitness when, low level. And instead of feeling stronger, I'm just feeling worse.
Feeling
So,
weaker.
yeah,
Okay. And then other than this problem, any other medical problems that you see your GP for on a regular basis?
no.
Okay. What medications do you take?
Leothyronine and natural desiccated thyroid.
Okay. And then are you allergic to any medications?
No,
No. Okay. And do you drink any alcohol?
only a couple of glasses at the weekend.
Okay, so not a significant amount.
No,
Is that glasses of wine or?
yeah.
Okay. Do you smoke?
No.
Have you ever smoked?
No.
Okay. And do you do any illicit drugs at all?
No.
Okay. And is there any family history of any medical problems?
Thyroid, and that's it.
Okay. And is there anything that you think might be going on?
I'm wondering whether my medication is right, whether it just needs to be looked at a little bit more, and maybe vitamins, or nutritional around that. So.
Okay. And, firstly, I think it's really important that you've come to see me today because clearly there is something wrong. Given that you've got a family history of thyroid problems, the symptoms you're describing, do sound like they're related to the thyroid. And also particularly given that you're on some thyroid medications, I think this is clearly all something that's going to be tying in together. Firstly, what I'd like to do is examine you in a bit more detail now, if that's all right.
Yeah.
Okay. And then what we'll do is we'll talk about the further tests that I'd like to do after that. Is that all right?
Yeah.
Okay.
Yeah.
So firstly, what I'd like to do is just have a look at your neck, if that's okay. So I'm just going to come to this side of you and then just have a look at things. Okay, give me a big swallow now, please. Would you stick your tongue out as well? Relax for me. Okay, I'm just going to have a feel of your neck now. Okay. And can you give me another swallow? And stick the tongue back out for me. And relax. And could you take your glasses off for me as well now, please? And just keep looking forward for me. I'm just going to have a look at your eyes. Okay, fine. You can put your glasses back on now. I'm just going to have a listen to your neck. Okay. And the next thing I'd like you to do is just put your hands straight out in front of you for me, if you would. Let me just have a quick look at them. Okay, and keep them straight out in front of you. That's great. I'm just going to take your pulse now as well, if I may. Okay. So now what I'm going to do is just test some of your nervous system, if that's all right.
Mm-hmm.
Okay. So what I'd like you to do now is just put your finger straight out in front of you, and then touch your nose. Touch back my finger again, and touch your nose, and touch my finger again. Touch your nose, my finger again, nose, my finger again, nose, my finger again. Okay, that's great. Now what we're going to do is just do some testing of your eye movements, all right? Okay, that's great. And now can I just get you to go like that for me? That's great. And then just do the same with the other hand. Great, thank you. Okay, so what I'd like to do now is just test some of the more central muscles in the body. And by doing that, we just get you to put your arms across your chest and then just stand up for us if you can. So if you could just do that for me, stand up. And then if you just stay standing for me, we'll just come over here towards the wall if that's all right. So what I'd like you to do now is just walk forward 5 or 6 paces. And then turn around and come back for me. That's great. So now what I'd like us to do is a more specialised test where it's just where we walk, where we just plant one heel to toe like that, one in front of the other. So you could just do the same sort of distance for me again. That's great. And then if you want to just come back for me. So a bit unsteady, but not too bad. Okay, yeah. Great. Now we'll just sit back down. One question that I forgot to ask earlier on was just about how you cope with different temperatures. Do you have any problems being in cold temperatures, hot temperatures?
Yeah, I'm not good. I don't like the cold.
Don't like the cold?
I'm always the coldest person.
Right,
yeah.
Okay. That's useful to know. So, firstly, there is something that clearly I think is wrong here. And I know you've seen a number of doctors in the past, but I think this is likely to do with the thyroid gland, which is something that I mentioned previously. But in order to get a more exact picture of what's going on, we need to do a few more tests. Okay. So first of all, I think it'd be good for us to get a bit more history from your family about what exact thyroid problems they have. Also, I'd like to do some blood tests, particularly looking at the thyroid function tests, and there's a number of different antibodies that are related to the thyroid gland that I think would be good for us to look at. Then I think it probably would be a good idea for us to do a scan of the thyroid, an ultrasound scan, to make sure that there's no abnormalities or enlargements or cysts or anything on the thyroid gland. And once we've got those scans, then we can make further plans about where we go from next, or if we need to change any of your medication to make things a bit easier for you.
Okay.
Have you got any questions you want to ask?
Just whether you think I'm on the right medication.
So, I think you might be on the right medication, but at the moment it's difficult for me to tell. The reason for that is what we need to do is do a proper test of your thyroid function through the blood tests that I suggested earlier. And once we've got those blood tests, we can see whether we're under-treating you or over-treating you, and also we'll be able to get a better picture of whether you're on the right medication. So when we bring you back for your next consultation, I'll have those results and we can go through things in more detail then.
Okay, great, thanks.
Thanks. So to complete my examination, I would like to do a full set of bedside observations, particularly looking at the patient's blood pressure and heart rate. I would like to do a full neurological examination, paying particular attention to the patient's reflexes, and do a cardiovascular examination.
Okay, so what is your diagnosis?
So with this patient, I think there are a number of potential diagnoses. Importantly, there's clearly this patient suffering from thyroid disease. But she has sort of a mixed picture of both hyper and hypothyroidism at different times. The differentials which could be causing this are firstly a de Quervain's thyroiditis. She could have Hashimoto's thyroiditis. She could have hypothyroidism, which is then having periods where the hypothyroidism is being overtreated with levothyroxine, or she could have had a previous hyperthyroidism that's then had radioactive iodine therapy, followed by periods of hypothyroidism and then over-treating with levothyroxine again. So at the moment it's not exactly clear what the cause of the problem is.
Okay.
The positive findings from the history that have led me to this are particularly the symptoms that she describes. So she describes periods of sort of memory loss and lack of focus. She describes periods of cold intolerance. She also describes periods where she had sort of muscle weakness and poor coordination. Also, she describes periods of significant weight loss followed by periods of significant weight gain, which come in a sort of a waveform type picture, which makes me think that she has periods of both hyper and hypothyroidism.
Okay. You mentioned a number of differentials there. Let's presume this is hypothyroidism. So can you just be a bit clearer? What have you got for hypothyroidism?
So this could be a de Quervain's thyroiditis, a Hashimoto's thyroiditis. It could be an age-related hypothyroidism, though in her case she's young and I think that's less likely. Or it could be an iatrogenic hypothyroidism.
Okay. Tell me about Hashimoto's thyroiditis.
So Hashimoto's thyroiditis is a chronic progressive condition where there is lymphocytic deposition within the thyroid gland, which causes thyroid gland destruction. There's an autoimmune association with it, and it's associated with anti-thyroglobulin antibodies and also anti-TPO antibodies.
Okay. So in a case of hypothyroidism, what's the first line treatment?
So the first line treatment would be through the use of levothyroxine medication, and then monitoring of the patient's generally T4 and TSH levels to ensure that they're within normal range.
Okay. So for this lady then, how would you investigate?
So for this lady, I would investigate her by firstly doing a set of blood tests. So we want to look at her TSH levels and her T4 levels. If I wanted further investigation, I would do her anti-TPO and her anti-thyroglobulin levels, and potentially also even a T3 level to get a further understanding of her thyroid function. I'd also want to do an ultrasound scan of her neck, particularly looking at the thyroid gland to see if there's any evidence of malignancy within the thyroid gland, or if there's any evidence of thyroid cysts or thyroglossal cysts.
Are there any other linked conditions to Hashimoto's?
So Hashimoto's thyroiditis is an autoimmune condition, which is linked to things like vitiligo, which was present in this case. This lady had a number of patches of depigmentation on her hands, potentially on other areas of her body, though we didn't examine them. It can also be linked to Addison's disease, so it's important to screen patients for Addison's who have evidence of Hashimoto's thyroiditis.
Okay. So you've told me a little bit about Hashimoto's thyroiditis. Can you tell me much about de Quervain's thyroiditis?
So de Quervain's thyroiditis is different from Hashimoto's, whereas Hashimoto's thyroiditis is a progressive condition. De Quervain's thyroiditis is a condition where there is a period of hyperthyroidism, where there is destruction of the thyroid follicles. You then have a period of hypothyroidism, where the thyroid follicles regenerate, and then following that there is the patient then becomes euthyroid again when the sort of equilibrium is restored. And that differs from Hashimoto's because Hashimoto's is something that progresses over a period of time.
Okay, thank you very much.
Thank you.
This lady has had symptoms and signs consistent with hypothyroidism. She has a systemic illness comprising of lethargy, muscle weakness and fatigue. She also has had weight gain, low mood and cold intolerance. She had symptoms of postural hypotension. Other features in general include menorrhagia, myalgia and psychotic symptoms. This lady also had hypopigmented areas on her hands, which could be vitiligo, and thin hair. Candidates should examine for a goiter or thyroidectomy scar, bradycardia, and features of cardiac failure. Patients can have myxedema. This is characterized by coarse, waxy skin with periorbital edema and thin, brittle hair. Hypothyroidism can also be associated with carpal tunnel syndrome, cerebellar dysfunction, and slow relaxing deep tendon reflexes. There may also be peripheral neuropathy. Bear in mind that this can also be caused by associated conditions such as pernicious anemia. The most common cause of hypothyroidism in the world is Hashimoto's thyroiditis, or chronic autoimmune thyroiditis. This is characterized pathologically by lymphocytic destruction of thyroid follicles. There can be transient features of hyperthyroidism during the acute inflammatory phase. Other differentials and causes of hypothyroidism include iatrogenic, either thyroidectomy for hyperthyroidism or thyroid cancer, radioiodine therapy, and drugs, most commonly carbimazole, propylthiouracil, lithium, interferons, and iodine. Other differentials can be de Quervain's thyroiditis and postpartum thyroiditis. In terms of investigations, thyroid function tests should be checked, particularly with TSH and free T4. Patients with symptomatic hypothyroidism will have high TSH and a low T4, but patients can also have subclinical disease whereby TSH is mildly raised with normal T4 levels. Antithyroglobulin and thyroid peroxidase antibodies are found in nearly all patients with Hashimoto's. A 9 AM cortisol should screen for adrenal function in cases where coexisting Addison's may be suspected. Lipid profile should be checked since hypercholesterolemia can be a complication. FBC looking for macrocytic anemia, and Usinase since hyponatremia can be a feature. Creatinine kinase can be elevated, and you can consider a thyroid ultrasound to look for the presence of a goiter, and in the same instance an FNA can also be considered. A chest x-ray may show you a retrosternal extension of a goiter. In terms of treatment, levothyroxine is the first line of choice. Typically 25 to 75 micrograms is a starting dose, titrated to response. Lower doses are recommended for those over 60 years old and with those with ischemic heart disease. Following treatment initiation, TSH and T4 levels should be checked at 8 to 12 weeks, with dose adjustments made accordingly.
Good morning.
Good morning.
My name is Dr. Farrant. Can I confirm your name, please?
Yes, it's Victoria.
Nice to meet you, Victoria. So what is it you've come to see me about today?
My speech and swallow are getting quite bad.
Okay. Do you want to tell me a little bit more about that?
Basically, I sound like I'm drunk, and it's when I'm swallowing, it takes me quite a while to swallow, and I'm choking occasionally.
Okay. And how long's that been going on for?
About 2 to 3 weeks.
2 to 3 weeks. Okay. So, we'll talk about the swallowing first. So, is it liquids you're having problems with or solids?
The solids are an issue because I can't chew them.
Mm-hmm.
And then liquids I'm choking on them.
Okay. And is it worse at any particular time of the day?
No.
So it's the same the whole way through?
Yeah.
Okay. And so if you say you had something that was slightly thicker, like soup or custard, is that easier or?
Yes, easier, yeah.
Okay. And this may be a weird question. Is it sort of initiating the swallow, or is it where do you feel stuff gets stuck, or?
A bit of both.
Right.
Yeah.
Okay. Is it painful at all?
No.
Right. And have you had any problems with sort of food coming back up, like vomiting or anything?
Just when the liquid goes down, it might come out my nose.
Come out your nose?
Yeah.
Okay. And that happens almost every time, does it?
Mostly, yeah.
Okay. And you said your speech is sort of. You said it sounds like you're drunk sometimes.
Yeah, it's a bit slurred.
Slurred.
Yeah.
Okay. Yeah, I can. I hope you don't mind me saying, but I can sort of sense that.
Yeah.
And is that something that is getting worse, or is it?
Yeah, getting worse.
And is that constant throughout the day, or does it get worse as time goes on, or?
Gets worse when I'm due my medication.
Right. Okay. I'll ask you about your medication in just a minute, if that's all right.
That's fine.
And have you sort of noticed any problems is it creating words, or is it everything just sort of being slurred? That's the main.
Just everything being slurred. It's like it's an effort to talk.
Okay. Any other problems that you've sort of noticed? Any sort of illnesses beforehand that triggered any of this, do you think?
No.
Okay, so it's just sort of come out of the blue that these things have started happening.
Yeah.
Okay. All right, so I'm just going to ask you some more sort of general questions now. Any problems with sort of headaches at all?
No.
What about your vision?
My eyes droop occasionally when I'm tired.
Okay.
Um,
And when you say they droop, do you mean your eyelids droop?
Yeah.
Or? Okay. And what about sort of your vision? Does your vision ever go blurred at all?
no.
What about double vision?
Occasionally double vision.
Okay. Now, is that double vision that's there all the time?
No.
Just when you're tired?
Yeah.
And when you're tired, is it double vision wherever you look, or is it just looking in one direction that makes it happen?
Looking everywhere.
Looking everywhere, you get double vision.
Yeah.
Okay. That must be quite difficult.
Yeah. Because I can't focus on anything.
Can't read or
No.
watch TV or
No.
anything. Okay. And then we've spoken about your speaking. What about your breathing? How?
It's okay, but I have to lie upright in bed.
Okay.
I can't lie flat.
Hmm.
So I have like about 6 pillows.
Really?
Yeah.
Okay. And is that sort of at night? Say if you lay down first thing in the morning, would that be all right? Or
No.
even then, you'd have to be propped up.
Yeah.
Okay. What about sort of coughing at all?
I could cough, but nothing's coming up.
Right.
It's just a dry cough.
Okay. So does it feel like there's stuff down there to cough
No.
up? Or okay. Fine. Any pains in the chest at all?
No.
Okay. Any palpitations, flutters in the chest, anything like that?
No.
Okay.
Sometimes it feels like it's a bit of an effort to breathe. Like more so than usual. Like if you've walked up the stairs, like it feels like that occasionally.
Okay.
But even though I haven't walked up the stairs.
Right. And your bowels are all right?
Yeah.
Bladder's okay?
Fine.
What about, your walking and things like that? Is that all right?
It is and it isn't. Because I can walk, but I fall.
Mm-hmm.
And I don't have any warning of that. So I'm a bit apprehensive of walking long distances because I need to rest.
Mm-hmm.
And obviously there's that fear of falling and not being able to get back up again.
Okay. Interesting. Well, I'll examine that in a bit more detail sort of in a minute, if that's okay. And then, do you have any sort of regular sort of medical problems that you see your GP about on a regular basis? No. Okay. Medication?
Yeah.
What medication do you take?
I'm on quite a lot.
Okay.
So I take prednisolone
Okay.
daily,
Okay.
pyridostigmine,
Okay.
lansoprazole,
Right.
cyclosporin,
Okay.
Adcal D3.
Okay.
I have a vitamin B12 injection every 3 months.
Right. Okay.
Um,
And for
Yeah.
someone of your age, that's quite a lot, really.
yeah.
Okay. And what about allergies? Are you allergic to anything?
Only azathioprine.
Right. So you've had a problem with azathioprine in the past?
Yeah.
Okay. Any family history of medical problems?
No.
Okay. Do you smoke?
No.
How much alcohol do you drink?
Hardly any.
Okay. Good. And clearly this is something, the swallowing's quite an issue, but day to day, is this affecting you quite a lot?
Yeah.
Okay.
I don't work anymore.
Right.
I used to work when I was 17.
Right.
I've had different careers. but now I'm not working.
Not working.
No.
Okay, so it's really quite affecting you a lot.
Yeah.
Okay. Well, you know, I think you've done absolutely the right thing in coming in to see me today, because this is clearly something that, one, is affecting you quite a lot, but I can see it must be worrying you a lot. You know, it's difficulty with swallowing and speeches. You know, it's not normal to have these sorts of problems. So what I think we need to do now is, you know, is me have a full examination of you and try and get to the bottom of what's going on. And then once I've done that examination, we'll have another chat and I'll talk about where we're going to go next.
Okay.
All right?
Yeah, that's fine.
Thank you.
Thanks.
Okay, so first thing I'm going to do is just test your vision. All right? So I've got a chart here, and I'm just going to get you to cover one eye and then just read the bottom line for me.
Okay.
All right?
Yeah.
Cover your left eye and then just read the bottom line for me.
YUHVTAOX.
And then the other eye for me.
YU. Looks like an N now. I'm just going to say N. VTAOX.
Great. Okay, and I'm just going to test your eye movements and the peripheries of your vision. Okay, so first of all, cover one eye with one hand, and then just tell me when you can see my finger working.
Yeah. 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 Yeah.
And then swap eyes for me.
Yeah. 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 Yeah.
All right, and now what we're going to do is just test the movement of your eyes. So just keep your head still, follow my finger. If you get double vision, tell me.
Okay.
All right? Any double vision?
A bit there.
A little bit there. Okay,
Yeah.
so just cover one eye for me. Has it gone?
Yeah.
Great, and then cover the other eye for me. Has it still gone?
Yeah.
And then open them both back up for me. Is it back?
Yeah.
Okay. Okay. Great. Double vision's all gone? Good. So can you now just pick a spot on the wall, and I'm just going to shine a light in your eye, okay? Okay, fine. So now what I'm going to do is just test the sensation in your face. So if you just close your eyes and tell me when you can feel something touch you.
Yeah. 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 Yeah.
Now just something slightly sharper, okay?
Yeah. 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 Yeah.
Okay. And now just some movement. So if you could just raise your eyebrows for me, and then puff out your cheeks, and hold them out there as long as you can. I'm just going to try and push them in. Okay, and then give me a smile. Okay. Shut your eyes really tight, shut. Keep them tight. I'm just going to try and open them. Okay. So now I'm just going to test the reflexes of your chin. So I'm just going to put my thumb on there. Okay. If you could clench your jaw for me now. And again. And again. Okay, that's great. So I'm now just going to test your hearing. So I'm going to come behind you, make some noise in one ear, and then say something in the other ear, okay?
Elephant. Giraffe.
Good. And now I'm going to tap this and put it on your forehead. I want you to tell me if it's loud on either side, okay?
Okay.
Same on both sides?
Yeah, both sides.
Good. And now I'm going to place this by your ear and then place it on the back of your ear and tell me which one's louder, okay?
First one.
Okay.
First one.
Good. So I'm just going to have a look in your mouth now, all right? So open wide for me. And just say R for me.
Ah.
Okay, that's great. And just pull down on your bottom lip for me now, if you would. That's great. Thank you. Okay, so now what I'd like you to stick your tongue out for me. And back in. That's great. And then just push your tongue against your cheek for me. Fantastic. And the other side. That's great. Now, turn your head against this hand for me. And the other way. All the way. There we go. Perfect. Right, now what I'm going to do is just check your shoulder movement. So shrug your shoulders up for me. Don't let me push them down. That's great. And give me a swallow. Perfect. Now what I'd like you to do is stand up for me and just walk up and down for me, just so I can see you walk. Okay, so could you just walk forward for me, please? And stop there, turn around and walk back. That's great, thank you. Okay, so the next thing I want to do is just check your arms, if that's all right. So can I just, first of all, to get you to go like that, and don't let me push you down. Okay, that's good. And now, can I just get you to go like that for 10 seconds or so, all right? And back up like that for me, and don't let me push you down. Okay, fine. So it's certainly weaker if we do that. Okay. And I can also see, just looking at your chest, you've got a few scars. Do you mind if I just have a quick look at them? All right.
No.
So we've got one there, and we've got a long one down there, haven't we? Okay. So the first thing I think it's really important that you come and see me today, because clearly there's something that's affecting you that we need to do some more investigation into. I think there is a specific condition that might be causing this, but there's some more tests that we need to do to prove it. So first of all, I want to have a bit more of a chat with you about some of your breathing problems, and also have a chat to you about your family history in a bit more detail. I'd also like to do some blood tests and some specialist blood tests, and then some lung function testing and a scan or an x-ray of your chest. And once we've got those test results, I'll come back and have another chat to you.
Okay.
So to complete my examination, I would like to take a full respiratory history, do a full respiratory examination, do some bedside lung function testing as well. Thank you.
Can you present this case back to me, please?
So I believe that this patient has myasthenia gravis. The reason for this is she presents with predominantly bulbar type symptoms of dysarthria and difficulty with swallowing. These seem to have got particularly worse over the last couple of weeks and months, though she did also have a number of other findings that were positive, particularly on examination, which make me think that this is myasthenia gravis. She had evidence of double vision, particularly on looking sort of downwards and to the right, which resolved, and then she also had evidence of fatigability when I was assessing her upper arms.
Okay. And what are the other differentials then for these presenting symptoms?
So the differentials would be a Miller-Fisher type syndrome or a Guillain-Barré, or it could be a Lambert-Eaton myasthenic type symptom.
Okay. So as a result, what investigations would you request?
So first of all, I would like to do just a routine set of blood tests, checking the patient's full blood count, looking for any evidence of infection with CRP, also checking her electrolyte levels. I'd also, historically in this case, I would have done a tensilon test, though that has been replaced now by anti-ACH receptor antibodies and also anti-MuSK antibodies, which are more specific for myasthenia gravis. I would also want to do a chest x-ray and then potentially a CT scan looking for a thymoma, though in this case, given her midline sternotomy scar, I do wonder whether she's already had a thymectomy.
Okay. Are there any other investigations that you would want?
So other investigations that we could do would be nerve conduction studies, particularly looking at nerves that supply the sort of the bulbar region.
Okay. And how about brain imaging?
So we could do a CT brain or an MRI scan of her brain to look for any further abnormalities there.
All right. So what treatments are available for myasthenia gravis then?
So first line treatment would be pyridostigmine, and then following that, patients can be treated with steroids, and then steroid-sparing agents such as azathioprine or mycophenolate, and then in severe cases we can look at treatment with IVIGs.
Okay. Let's talk about steroids. Can you think about any issues with treatment with steroids and myasthenia?
So first of all, patients can get a steroid dip when they first start their steroids in cases of severe myasthenia. So in particular, what we need to do is patients with severe myasthenia need to be admitted to hospital for commencement of their steroid therapy to ensure that they don't develop a myasthenic crisis. There are also long-term complications associated with prolonged use of steroids. So patients can develop diabetes, they can develop a Cushingoid appearance, they can also there's an increased risk of heart disease and stroke as a result of steroids. They can get thinning of the skin and easy bruising, and there's also adrenal failure, which can result from prolonged steroid use. So if we ever try and taper a patient's steroid dosage, it's important to monitor for signs of adrenal failure.
Okay. So going back to myasthenia gravis, what is the most serious complication?
So the most serious complication of myasthenia gravis would be a myasthenic crisis. Now there are a number of triggers for myasthenic crisis, but predominantly it's patients where they have an infection, or if they've had an operation, or if we've tried to withdraw their therapy, so withdrawing their steroids or their steroid-sparing agents, then they can develop a myasthenic crisis where they get severe muscle weakness, and particularly respiratory failure can occur. So it's really important that patients who we think are at risk of a myasthenic crisis have lung function testing, paying particular attention to their forced vital capacity.
Okay, thank you very much.
Thank you.
This patient has presented with fluctuating bulbar symptoms of dysarthria and dysphagia. There is also weakness of the muscles and mastication. She has had no clear triggers. Furthermore, she complains of ptosis and occasional diplopia. There are symptoms suggestive of orthopnea and occasional exertional dyspnea. This could be due to respiratory muscle weakness. She is on immunosuppression as well as pyridostigmine. Clinically, she has a nasal tone to her speech. Visual acuity and pupillary reflexes are preserved. Facial sensation is intact. Muscles of mastication have normal reflexes and bulk. There was no ophthalmoplegia evidence, but she did experience diplopia, which settled on closing each eye. Proximal upper limb fatigability was evident. There was a tracheostomy and midline sternotomy scar suggestive of previous prolonged ventilation and a previous thymectomy. Patients with myasthenia gravis have fluctuating skeletal muscle weakness. Candidates should examine for fatigability manifested by worsening contractile force with repetitive movement. Patients complain of weakness of specific muscle groups and not generalized fatigue. Myasthenia gravis is an autoimmune neurological condition resulting from antibody-mediated destruction of the postsynaptic acetylcholine receptors. It is characterized by fluctuating weakness in a combination of ocular, bulbar, limb, and respiratory muscles. Typical patterns include ocular myasthenia, whereby weakness of the eyelid muscles often leads to ptosis. It can often be asymmetrical, and ptosis often worsens with sustained upward gaze. Involvement of extraocular muscles can lead to diplopia that is either horizontal or vertical. It resolves when occluding or closing one eye. Eye movements are weak and do not conform anatomically to the distribution of one nerve or muscle. The pupils are always spared. Bulbar symptoms. Involvement of muscles of mastication can frequently result in fatigability whilst chewing. Patients can have dysphagia and dysphonia with nasal speech due to weakness of palatine muscles, or hypophonia, that's low intensity speech. This worsens with prolonged speech. There is a risk of aspiration which can induce a myasthenic crisis. Skeletal muscles. Patients can have skeletal muscle weakness resulting in an expressionless face. Weakness of the orbicularis oculi and oris muscles can be elicited on examination. Limb involvement usually manifests as proximal weakness, upper limbs being more affected. Neck muscle weakness can result in the so-called dropped head syndrome. Respiratory muscle involvement can lead to respiratory insufficiency and is one of the more serious sequelae. Impending respiratory failure is life-threatening and is called a myasthenic crisis. It can occur spontaneously as a part of a relapse of the disease or be precipitated by various factors, including surgery, infections, medications, or tapering of immunosuppression. More than 50% of patients present with ocular symptoms. Of these, roughly half go on to develop generalized symptoms within 2 years. Many patients without ocular disease will go on to develop this during the course of the disease. Approximately 15% of patients present with bulbar symptoms, and only 5% present with isolated proximal limb weakness. Differentials of myasthenia gravis include ocular myasthenia, thyroid ophthalmopathy, brainstem and cranial motor weakness, and myotonic dystrophy. For generalized myasthenia, generalized fatigue caused by, for example, anemia, it is therefore important to differentiate between lethargy and weakness of specific muscle groups. Motor neuron disease. The important distinguishing factors here are the presence of both upper and lower motor neuron symptoms, as well as muscle atrophy and fasciculations, which are absent in myasthenia. Electrophysiological studies can also help to differentiate. Botulism can often be confused with myasthenia gravis due to bulbar and ocular involvement. The difference here is involvement of the pupillary muscles, which are spared in myasthenia. Furthermore, it progresses more rapidly. Lambert-Eaton myasthenic syndrome, or LEMS, is an important differential. This is commonly a paraneoplastic autoimmune disease of the synapse, the main association being with small cell lung cancer. As opposed to myasthenia, symptoms are worse in the morning and improve as the day goes on. Repetitive nerve stimulation produces improvement in the compound muscle action potential. Investigations. Anti-ACH receptor antibodies are present in more than 80% of those with generalized myasthenia and more than 50% of those with ocular myasthenia. A tensilon test with IV edrophonium assesses immediate and short-acting effects of acetylcholinesterase, but with autoantibody testing is less commonly used. Anti-MuSK antibodies, that's muscle-specific kinase, can be sent in those negative to the above. Voltage-gated calcium channel antibodies are present in Lambert-Eaton myasthenic syndrome. Repetitive nerve stimulation and electromyography shows decreasing muscle action potentials. MRI brain should be done if bulbar and ocular symptoms are present. Thyroid function tests and CT and ultrasound of the orbits if thyroid ophthalmopathy is suspected. CT chest should be conducted to look for thymoma. There is an association, and thymectomy can attenuate the symptoms of myasthenia gravis. Treatment. The mainstay is anticholinesterase, for example pyridostigmine, which is a long-acting cholinesterase inhibitor. Immunosuppression can be used with prednisolone and azathioprine as a steroid-sparing agent. Serum TPMT levels should be checked prior to azathioprine therapy, and low levels are a contraindication. Surgery for thymoma can be considered, particularly where the onset of myasthenia is under 40 years old.
Good morning.
Hi, good morning.
My name's Dr. Farrant. Can I just confirm your name, please?
Yeah, my name's Jane Ainley.
Nice to meet you, Mrs. Ainley. What is it you've come to see me about today?
Over the last day or so, I've just felt just generally unwell, and I've had a little bit of tummy pain here.
Okay. So whereabouts in your abdomen is the pain?
Well, it's here at the front, and then it seems to just go around. I've got a little bit of backache as well here at this side.
Okay. And how long's that been going on for?
The tummy pain started probably 24 hours ago, about a day ago, something like that, and then probably my backache probably about 6 hours ago, something like that.
Okay. Have you had any temperatures with it, or?
I've had a little bit of a temperature. Just felt a little bit hot, and just, as I say, just out of sorts, really.
And what kind of pain is it? Is it sharp? Is it dull?
It's just a dull ache. I wouldn't say it's particularly sharp. You just know it's there, and it's just uncomfortable and achy.
Okay. And is it better or worse in any sort of a position, or?
Not really. I tried to take a paracetamol and thought, well, I'll just try and sleep it off and see if I feel a bit better, but didn't really make an awful lot of difference.
Okay. Have you had any problems passing urine at all?
Well, I know it sounds awful, but when I go for a wee, it's a little bit cloudy, and it does smell a little bit as well.
And did that come before the sort of the pains in the abdomen, or?
Yeah, it's been a little bit cloudy, and then sort of my tummy started to ache, probably simultaneously about the around about the same time.
Okay. And does it hurt when you pass water?
Not particularly. Sometimes I feel I really, really need to go, and then when I try and go, it's only a little dribble, and there's not an awful lot there.
Okay.
So I feel I'm going to the toilet probably more than I used to, but then not going a lot, if that makes sense.
Okay. And have you had problems with your bladder in the past?
On and off, I've had a few problems. A couple of it, and they said it was a bit of an infection, but that was, probably a couple of years ago now.
Okay. So you have had infections previously?
Yeah.
Okay. Other than the problems with the what sounds like potentially an infection in your urinary system, have you been feeling unwell in any other way recently?
Well, I was a little bit sick, but I've only been sick just the once. And then I've had, I don't know, just feeling completely out of sorts, really, just not myself, and just a little bit, I don't know, disorientated, just not really with it. And as I say, it started off a pain here, and then a bit of a dull ache here in my back as well.
Okay. And have you had any problems with your bowels at all?
I've always had problems with my bowel on and off. It sort of yo-yos between not being able to go and then going and having like a diarrhea.
Okay. And has that been investigated?
It has. I mean, I have some medication to try and keep it on the level, to try and keep, so that I don't get to the stage where I'm so blocked up, it becomes painful, and that medication seems to regulate it quite well.
Okay. And have they found a cause for what sort of is causing you to become so constipated on a regular basis?
They've just said that I've got a sluggish bowel, and the muscle tone just doesn't move everything through very well. So I just need something to help soften all my movements up.
Okay, fine. And you said you've been vomiting. Has your appetite changed at all?
Yeah, I think because I've been sick, I just don't feel as though I want to eat. I'm not particularly hungry, so I haven't really been eating. So whether that's stopped me being sick again, because after I was sick, I haven't really eaten very much.
Okay. And just a few more general questions now. So have you had any headaches at all?
Not particularly a headache, really. I wouldn't have said.
Okay. Any visual problems?
No, I don't think so.
Is your breathing all right?
Yeah, fine. You know, it
No
doesn't
cough
seem
or anything like that?
Nope, nothing at all.
Good. Any chest pains?
Nope,
Palpitations?
no.
Good. And you said you've been vomiting. Is it just sort of bile that you've been vomiting up, or have you noticed any blood in the vomit?
It was just like a bit of food and then some yellowy liquid.
Right. Okay. We've covered the bowels. Is your walking all right?
I'm okay. I've got a bit of a problem with one of my legs. It's a bit weaker than the other one, but I haven't actually noticed any deterioration in that.
Okay. So you have a long-term problem with your legs, but your walking's still all right at the moment.
Yeah.
Okay. And you sort of mentioned a couple of different problems. Is there an underlying diagnosis that brings all of that together?
I was born with spina bifida.
Okay.
And they've kind of said that anything below where the spinal cord is damaged will always be not working probably as efficiently as it should do.
Okay.
So I've been told to expect that there's going to be issues ongoing where things aren't going to quite work properly.
Okay, so that's what probably is the thing that's caused the issues with the bowel and with the bladder. Have you had problems with incontinence in the past?
Yeah, I am urinary incontinent. Sometimes it's perfectly fine. Then other times I can just wet myself, unfortunately.
Okay, fine. So you need to wear sort of pads or anything like that?
Yeah, I wear continence pads all the time. Yeah.
Okay. And what medication do you take for this?
For the urinary incontinence, I'm on a tablet called Solanaficin and another one called Betmega.
Okay.
Because they said that the bladder was underactive, and that's why there's issues.
And any other medication that you take?
I take gabapentin for pain,
Okay.
back which is trying to stop spasms. As mesbrosol, that's to try and help me get a little bit of reflux.
Okay. Are you allergic to anything?
Yeah, I get hay fever, and I'm allergic to quite a lot of animals and grass and pollens and flowers, so I take an antihistamine all year round as well.
Okay. Do you smoke?
No.
Have you ever smoked?
I did when I was a teenager, but I actually packed in when I was about 19, so
Okay.
a
So
long time ago.
just a couple of years.
Yeah.
How many a day did you smoke?
It was only when I was out.
Okay. Do you drink any alcohol?
No.
Good. Is there any family history of other medical problems that I should know about?
No. My dad he's in heart issues, but he's 79, so
Okay.
I don't think there's anything.
That's to be expected.
Yeah, there's nothing for young people really.
And what are you particularly worried about today?
Just this ache in my tummy and going round, and just this general unwell feeling. I don't want to do anything. I just don't feel very well.
Fine. Probably the next best thing for us to do is for me to get you on the couch and have an examination of your abdomen, and I'll have a feel of your back as well. And then once I've done all of that, I'll have another chat to you about where we're going to go next.
Okay, that's fine.
I'm just going to take a quick look at you now. Just take a nice deep breath in for me, please, and out. Give me a cough, and just raise your head forward if you would. That's perfect, and relax back. Okay, can I just have a look at your hands first of all, please? And turn them over for me. And back over. Just relax that hand down for me. Just put your hand straight out in front of you like that for me, and then just cock your wrists back, hold them there. And relax down. You can have a look at your eyes now, so could you just pull down on one of your eyelids for me? That's great. Relax. Open your mouth for me. Lift the tongue for me. That's great. Now just rest your head back, look towards the wall for me if you would. Do you have any pain in this part of your abdomen?
No, that one's fine.
Okay, I'm just going to press on it, okay? That's fine. If you could just sit forward for me now. Give me a quick feel of the neck. Okay, just going to have a look at your back now, all right? Is that tender in that region?
No, it's fine.
Is it tender over here?
Yeah, that's
That hurts there. Yeah. What about here?
No, that side's okay.
Okay. What we'll do now is we'll lie you down flat and then I'll have a feel of your abdomen. Okay, just going to have a general look at your abdomen now. And this bruising on your abdomen, is it related to your condition?
No.
Okay. Now, I know it's tender on this side. Okay, I need to have a feel of your abdomen, but I'll be gentle on this side as much as I can. All right?
Okay,
If
yeah.
things are tender, just tell me.
All right.
Any tenderness there?
No, it's fine. There's a little bit sore there. Yes, there.
That's bad.
That's tender. And
And
there.
there. Okay, just a little deeper now. And that
Yeah,
hurts
that's
there. Okay, I'll be gentle.
That's really
there.
sore there.
Okay, fine. Nice deep breath for me now. And out. And again. And out. And again. And out. And again. And out. And again. And out. One more. And out. And again. And out. And again. And out. And again. Sorry.
Sorry.
And out. Last one. And out. Okay. I know it's tender, but I need to just try and have a feel around where your kidney is. Okay, so if you could just roll towards me slightly. And back down. That hurts there. Sorry. And if you could just roll the other way for me. And back down.
No, that side's fine.
Okay. Right. Just gonna have a tap there now as well. Does that hurt?
No.
Okay. Okay, we'll just cover you up a bit now. All right. Then I'll just have a look at your legs. Okay.
Okay.
Okay. So, firstly, I think you've done absolutely the right thing in coming to see me today. Given your underlying condition of spina bifida, you are at an increased risk of developing urinary infections, which can go to the kidney. And given the sort of the temperatures that you've been having and where you're tender, I am worried that this is a kidney infection. So the things I want to do next are to check your observations, check your urine, do some blood tests, all right, and then I think it's likely that we're going to need to start you on some antibiotics quite quickly, because if this is a kidney infection, it's something that normally needs antibiotics through the drip, okay, and some intravenous fluids as well, okay. Do you have any concerns or any questions you want to ask?
No, that's fine.
Okay, thank you. So to complete my examination, I would like to do a full neurological examination, check the patient's bedside observations, and perform a urine dip.
Can you please present your findings from this case?
So this patient, I believe, has pyelonephritis. The positive clinical findings which have led me to this diagnosis are firstly that she presents with a 24-hour history of abdominal pain, particularly radiating to the left flank, and she's been feverish with associated foul-smelling urine and discoloration of her urine. On examination, she is tender in the left flank, and on blotting of the left kidney there was significant tenderness. So the main sort of diagnosis in this case I think is pyelonephritis, but importantly she also has spina bifida, which I think has likely contributed to the condition.
How do you think the spina bifida has contributed to her developing pyelonephritis?
So patients with spina bifida can regularly have problems with incontinence, and that's something that she elicited too, and the sort of neuropathic bladder that will result as from having spina bifida leads to structural abnormalities, which in turn can cause patients to develop recurrent urinary tract infections and, in the worst case scenario, pyelonephritis.
Can you tell me what the difference is between a complicated and an uncomplicated urinary tract infection?
So an uncomplicated urinary tract infection is classically seen in premenopausal women who have no specific structural abnormality in the bladder or in the urinary tract. A complicated urinary tract infection is one that's seen firstly in any man or in any patient who has a structural abnormality. That can be due to a compression from something like a benign prostatic hyperplasia, or any intrinsic complications such as vesicoureteric reflux.
How would you next investigate this patient?
So I'd want to do some urgent investigations on this patient, as I'm concerned about sepsis and a significant infection in her case. So we would want to do some urgent blood tests. I would want to do blood cultures and a urinary culture. And given my concern about a structural abnormality with this patient having spina bifida, I would want to do at least an ultrasound scan of the kidneys and potentially a CT-KUB if needed.
How would you manage this patient?
So, first of all, I would want to bring her into hospital. She would require urgent intravenous antibiotics within an hour of first presentation to hospital. She would also likely require intravenous fluids.
Can you list other associated features or conditions with spina bifida?
So, spina bifida can present with a large range of conditions. In this case, she has evidence of a neuropathic bladder, but also there's some concern that she has, with her recurrent constipation, that there's some neuropathic bowel as well. I would also be concerned about leg spasticity, and she did mention that she was on baclofen. There's also cerebral complications which can occur as a result of spina bifida. Patients can have hydrocephalus, which can sometimes require a VP shunt being inserted. They can also develop Arnold-Chiari malformations. They can have recurrent meningitis. They can also develop syrinxes.
What are the risk factors for developing spina bifida?
So it's normally things that are related to the mother, particularly having a deficiency in folate. Therefore, any couples who are considering trying for a baby, it's important that they are counselled and that the mothers are started on folate therapy. Also, any families where there's a family history of neural tube defects, their children are at an increased risk of developing spina bifida. And there's also medications that can cause patients to be at risk of having children with spina bifida. In particular, that's anti-epileptic medications such as sodium valproate and steroid-sparing medications like methotrexate, which affect the folate metabolism. Also, patients who have diabetes and their blood sugars are very poorly controlled, they can be at risk of having children with spina bifida as well.
Okay, thank you.
Thank you.
Urological complications are a major cause of morbidity and mortality in patients with spina bifida. Patients are prone to developing a neuropathic bladder with a high pressure system and poor bladder emptying. This increases the risk of urinary tract infection as a result of urinary stasis, which increases the time for bacteria to invade the urothelium and thus cause disease. Patients can also go on to develop hydronephrosis, renal scarring from infection, subsequent renal impairment, and even progression to end-stage renal failure. The key to long-term urological care is to ensure a low bladder pressure. This can be achieved with regular, clean, intermittent catheterization along with antimuscarinic agents. In those patients who suffer recurrent urinary tract infections that can be defined as 2 or more infections in 6 months or 3 or more in 1 year, long-term prophylactic antibiotics can be prescribed. In this case, the patient's symptoms point towards pyelonephritis, given the history of fever, abdominal and loin pain, and vomiting. In pyelonephritis, a complete septic screen should be completed, including blood and urine cultures, to confirm the infective agent. Antibiotics should be started according to the local hospital policy, but would also be guided by the patient's previous microbiological history. Imaging with an ultrasound of the renal tract or a CT abdomen may be needed in those not improving with initial treatment with IV fluids and IV antibiotics in order to rule out an infected and obstructed system, in other words, a pyelonephrosis, which is a urological emergency and requires urgent drainage with a nephrostomy.
Good afternoon. My name is Dr. Farrant. Can I just confirm your name, please?
Carl Jones.
Nice to meet you, Mr. Jones. So, what is it you've come to see me about today?
So a couple of weeks ago I was playing football and noticed I was getting really breathless.
Okay.
And getting quite lightheaded and fuzziness in my head.
Okay. So this was breathlessness when you were exerting yourself?
Yeah, playing football, yeah.
Okay. And are you breathless normally?
Not really, not that I noticed, no.
No, okay. Is it just the one episode of breathlessness that you've had on exertion, or is it, if you went upstairs or anything like that, do you get breathless as well?
Not particularly, no. It was a lot worse than I've noticed before, like to the point where I actually really noticed it.
Okay. So this is just one episode of strenuous exercise that led to breathlessness?
Yeah.
Okay. Did you have a cough with that?
Kind of, yeah. Just as in, again, like just because I was breathless, just trying to catch my breath.
And at the time, had you been feeling unwell in any other way? Did you had sort of...
No, I was actually fine, yeah, completely fine. And I hadn't noticed anything, like I say, before.
Okay.
Either.
So you didn't have like a cold or anything like that? No,
No,
sort of
no.
headaches or... Okay. Did you get any palpitations at that time?
No, I don't think so.
Okay. Any pains in the chest?
A little bit like tightness kind of thing. Again, I think it was again down to my breathing.
So the tightness, was that sort of a heaviness, like someone was sat on your chest, would you say?
Yeah, could say that, yeah.
Okay. And did you get dizzy at all with that?
A little bit, yeah.
Did you black out or?
No, it was just like kind of like a migraine, it's that type of headache and that dizziness.
Okay. Has this ever happened before?
Not really, no. Not that I can remember.
Okay. So, have you ever had any episodes where you've blacked out in the past or?
Not really, no.
Okay. And so just a few other general questions. Did you get any visual disturbances with this?
It was kind of like a migraine, as in like it was fuzzy, as in what I could see. And it was almost like it was really bright. The brightness had gone up as well. But it was just more of like the headache kind of feel.
Okay. And Did you have like a sore throat with that or anything?
No.
No? Okay. And did you have any vomiting or nausea at the time?
No.
Okay. Have your bowels been okay?
Yeah.
And any problems with your urinary system?
No.
Okay. And then sort of when this came on, did you have any weakness in your legs at all, or?
Slightly, again, because of the running around, I think.
Any loss of sensation anywhere?
No, not really.
Okay. And do you have any sort of medical problems at all that I need to know about?
No, I had an operation when I was a baby, but don't know much about it.
Okay. Well, I'll have a look at you and see if you've got any scars and see if that can give me any clues as to what's going on. But I'll do that when I'm examining you. And are you on any regular medications?
No.
Okay. Are you allergic to anything?
No.
Is there any family history of any medical problems that I should know about?
Not that I know of.
Okay. Do you smoke?
No.
Have you ever smoked?
Maybe once.
Okay. Do you drink any alcohol?
Yep.
So how often do you drink alcohol?
A few days a week.
Okay. And so on a typical day where you have a drink, how much would you have to drink?
I don't know. Fair bit, I guess. Probably more than the average.
Okay. Is it beer, wine, or spirits that you would normally drink?
Bit of both, beer and spirits, really.
Okay. And so, just sort of more than the average. That's what you would normally say.
I'd probably say so. Yeah.
Okay. Do you do any illicit drugs or anything like that?
No.
No. Okay. So, clearly this is something that is affecting you, and I think you've done the right thing by coming and talking to me today. It's not normal for someone of your age, because how old are you, did you say?
26.
26. So it's not normal for a 26-year-old gentleman to be suffering like you are. When you're exerting yourself, you should be able to sort of run, at a better pace than it says that you've been doing, and you shouldn't be getting breathless or dizzy when you exert yourself. So this is something that we need to investigate in more detail, certainly. And I'm sorry that this is affecting you and it's stopping you from doing the exercise that you would like to do. So what I'd like to do now is for us to try and get you onto the couch, okay, and do a full examination where what I'll do is I'll examine your lungs, I'll examine your heart, and have a sort of a general look at you as well, and see if there's anything that we can find that might be sort of causing this. And then once we've done that, then I'll have another chat to you about the further tests that I'd like to do from there to investigate this further.
Yeah. Okay.
Is there any other questions you'd like to ask, or is there anything that's worrying you that you haven't mentioned?
No, don't think so.
Okay. Well, let's get you on the couch and we'll go from there.
Cool.
Okay, so what we're going to do now is I'm going to have a full examination of both your heart and your lungs and anything that's sort of related to that. Okay. What I'd like to do first is just have a look at you from the end of the bed. All right. Okay, so I'm just going to have a look at you now. So if you could just take a nice deep breath in for me, please. And out. And give me a cough. Okay. Can I have a look at your hands now, please? And turn them over for me. Just hold them there. You can relax that hand down now. Can I have the other hand now? Do you have any pain in your shoulder?
Not really, no.
Okay, I'm just going to let me take the weight of your arm now. All right, I'm just going to lift it up. Okay. What I'd like you to do now is just look over towards that wall for me, if you would, and just relax your head back. Okay. Do you have any pain in your abdomen?
No.
I'm just going to press on it. And look forward for me, please. I'm just going to feel the pulse in your neck. What I'd like you to do now is just pull down on your eyelid for me, please. Okay. Can you open your mouth for me now, please? And lift your tongue. That's great. Okay. I'm just going to have a look at your chest now, all right? Okay, just going to place a hand on your chest. Okay, could you just roll onto your left side for me, please? Okay, and back onto your back for me. Deep breath in and hold. And breathe normally. Okay. What I'd like you to do now is just sit forward for me, if you would. Okay? Deep breath in for me, please. And hold. And breathe normally. Just stay sat forward for me. I'm just going to have a look at your back now, all right? Just going to have a listen to your back now. Deep breath in for me. And out. And again. 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 And out. Okay, if you just lie yourself back down for me now. Just going to have a look at your legs now. And do your ankles ever swell?
No.
So what I would say first of all is you've done absolutely the right thing in coming to see me today. It's not normal for someone of your age to be feeling dizzy and breathless when they exert themselves, so it needs more investigation. What I'd like to do is some blood tests, a tracing of the heart. I'd like to do some blood cultures. I'd like to check your urine and send you for a CT scan of the chest, an X-ray of the chest and an ultrasound scan of the heart. When we've got those tests, I'll come back and have another chat to you. Have you got any other questions you want to ask me today?
No.
Thank you. So to complete my examination, I'd like to perform a full set of bedside observations. I'd like to do an ECG and I'd like to dip the patient's urine.
Can you talk me through your clinical findings?
So this gentleman presents with a history of exertional breathlessness and pre-syncope. He has a history of some previous surgery as a child, and that's also evidenced on examination by a left lateral thoracotomy scar. Peripherally, there are no other significant findings, but on auscultation of the precordium, he has a pansystolic murmur, which is loudest at the left sternal edge. That murmur is louder on expiration compared to inspiration, and he also has a murmur sort of evident at the lower border of the left scapula. I believe that the diagnosis in this case from that is that this gentleman has had a previous coarctation of the aorta, which has been repaired, but he also potentially has a ventricular septal defect, which currently has a left to right shunt.
Okay. Why is the murmur of a ventricular septal defect louder on expiration?
So in this case, with it being a left to right shunt, on expiration, the venous return to the left side of the heart increases on expiration, which therefore increases the character of the murmur.
How will you investigate the patient?
So there are a number of investigations which I think are important to carry out in this gentleman, as I mentioned to him earlier. First of all, I think it's appropriate for us to do a full set of bloods to check if he has any evidence of infection, and also to check that his kidney function is appropriate. Then I think it would be a good idea for him to have 3 sets of blood cultures, as he's a young gentleman with a murmur, and I think it's important that we don't miss infective endocarditis in this situation, though there were no peripheral signs to suggest infective endocarditis. Following that, we should be doing an ECG to look for any evidence of left ventricular hypertrophy. And then I would like to do a chest x-ray. Chest x-ray importantly would look for cardiomegaly and also any evidence of rib notching, given the concern about a previous coarctation. Then I would like to do a CT aortogram to see if there's any evidence of a coarctation or of a coarctation repair. Then finally, I think it would be appropriate for us to perform an echocardiogram scan on this patient. Importantly, during the time of the scan, I would want to look throughout the ventricular septum for any evidence of a defect on colour wave Doppler.
Okay. What are the treatment options for this patient?
So the treatment options very much depend on the findings from the investigations. If there's a ventricular septal defect evident on the investigations, then management would depend on the patient's symptoms. If there is evidence of left ventricular failure or of reversal of the shunt from left to right to left, then we would need to consider closure of the VSD. That would be through surgical options, through a patch or a VSD closure device. With regards to the coarctation, I think this has previously been repaired given the surgery that he's had. And if it was failing, if there was a further stenosis at the site of the surgery, there would be two options. One would be endovascular stenting, or the second would be a further surgical open repair.
So you mentioned this patient did not have any peripheral stigmata of infective endocarditis. Can you list me some signs that you might expect to find in someone who does have endocarditis?
So the history is important in patients with infective endocarditis. You want to screen patients for evidence of recent dental procedures that could involve, or also patients who have had intravenous drug use, particularly in this age group. It's important to check for that. Peripheral signs to look for are if patients have evidence of splinter hemorrhages, looking at the nails, Janeway lesions, Osler's nodes, Roth spots on inspection of the eyes, any evidence of septic emboli peripherally, and patients can also have evidence of hematuria on urine dipstick testing.
Okay, thank you.
Thank you.
Coarctation of the aorta describes a congenital narrowing of the aortic arch that usually occurs distal to the left subclavian artery. It is most commonly associated with other cardiac abnormalities, such as a bicuspid aortic valve in 50 to 80% of cases, a ventricular septal defect, or a patent ductus arteriosus. Non-cardiac associations include Berry aneurysms and Turner syndrome. Aortic coarctation can present in infants as severe heart failure, or later in life in adolescence or adulthood as unexplained hypertension or even heart failure. The variable presentation is believed to be due to the degree of narrowing that is present and the formation of collateral arterial supply. In adults, symptoms can occur due to hypertension, such as headaches or epistaxis, or with symptoms of heart failure, such as shortness of breath on exertion. Leg claudication can also occur due to reduced blood flow to the lower body and extremities. There are a number of clinical signs that may be present. These include radial delay, weak femoral pulses with a right-sided radial or brachial femoral delay. On auscultation, various murmurs may be present. For instance, a systolic ejection click from the presence of a bicuspid valve, or a pansystolic murmur in the setting of a ventricular septal defect. Continuous murmurs or bruits from adjacent arterial collaterals may be heard, such as over the scapula, anterior axillary areas, and the left sternal edge. The coarctation itself may produce a short mid-systolic murmur, which can be heard over the left infraclavicular area, but is most loud posteriorly under the left scapula. Also, in a female patient with Turner syndrome, signs may be elicited such as webbing of the neck or a wide carrying angle. With respect to investigations, an ECG may show left ventricular hypertrophy due to hypertension, and a chest X-ray may show symmetrical rib notching or a classic figure 3 sign of the aorta. Rib notching occurs due to collateral blood flow through posterior intercostal arteries causing notching on the posterior ribs, typically the 4th to 8th ribs. In the figure 3 sign, the initial bulge forms due to dilatation of the left subclavian artery. The sharp indentation is at the point of the coarctation, and the second bulge is the post-stenotic dilatation. Other investigations would include echocardiogram and CT or MR aortogram to more accurately characterize the anatomy. If coarctation is left uncorrected, complications can occur such as stroke, heart failure, and aortic rupture. Management involves balloon angioplasty and stent placement, but surgery with resection and end-to-end anastomosis is the preferred option.
Good morning.
Good morning.
My name's Dr. Farrant.
My name is Steve.
Nice to meet you. What is it you come to see me about today?
I'm feeling very tired. My joints are aching and a bit swollen.
Okay. And how long have you been feeling like this for?
Quite a long time.
Okay. With the tiredness, first of all, is it do you think your sleep's not as good?
No, the sleep certainly isn't very good. It's really full fatigue.
So it's affecting you all the time?
Yes.
Okay. And when you say your sleep's not very good, in what way?
I'm waking up quite a few times a night, probably 5 or 6.
Okay. And is it the painful joints
It's
that's
the
waking
painful joints that...
Okay. So you're still sleeping the sort of the normal amount of time, but you're just waking up sort of extra periods during the night than you would do normally?
Yes.
Okay. And then during the day, you're feeling tired as well? Or?
Yes, I tend to have a sleep in the afternoon.
Okay. And, you know, is there anything you think that might be causing that?
I don't know. It's probably why it's...
Okay. Yeah, that's absolutely fine. And so the joints, how long have they been sort of painful for?
In years.
So, you know, I can see that there's a bit of deformity in your joints.
Yep.
So, you know, is clearly a condition that's been affecting you for a long period of time?
Yes, it has.
Okay. And are there any joints in particular that are hurting the most, or?
My wrists, my fingers, my shoulders.
Okay.
Ankles.
And your ankles as well. Fine. And so what does this sort of pain in the joints stop you from doing?
It stops me from doing any lifting. It stops me from doing fine movements. Stops me from doing virtually any sport. It's almost impossible. So most sort of things that you would normally do.
Mm. Are you able to wash yourself and dress yourself?
Yes.
Okay. Eating, how's that with the joints the way they are at the moment?
They're fine, but we've got special
equipment.
Tools, yeah, cutlery.
Okay. And do you get problems with stiffness in the joints?
Yes, especially first thing in the morning. It lasts for up to 2 hours.
Okay. And then after that, they tend to be pretty good, do they? Or
they're better, but they're not pretty good. They're certainly not normal anyway.
Okay. And is the pain sort of worse at any different times of the day?
Pain's always worse in the morning. It's following activity. It can be quite painful.
Okay. And does any sort of particular temperatures make things worse, or?
No.
Okay, so your joints aren't stiffer when they're cold?
No.
Okay, fine. You mentioned swelling as well. Are there any joints in particular that swell?
Yeah, my hands.
Your hands?
Wrists, ankles.
Okay. And do they feel hot, tender
Yes.
at all, or?
Yeah, they feel hot and tender.
Okay. And you know, is the swelling getting worse at the moment, do you think, or is it?
No.
So it's just been pretty
It's
constant.
Fairly constant.
Fine. All right. And some more general questions now. Do you get any problems with headaches at all?
Headaches, no.
Okay. And how's your vision?
Vision is very good.
Okay.
Acuity is very good.
Okay. Do you get any sort of problems with your eyes at all, or?
I've had a very severe problem with my left eye.
Okay. Tell me a little bit more about that.
It was very painful and very, very sore, especially in strong sunlight. and I've been diagnosed with scleritis.
Okay. And is there anything that you think might have brought that on?
I was told it was probably caused by a biologic drug that was given about 3 years ago.
Right, okay. And so I'll have a look at your eyes in more general when I examine you later. Any problems with your breathing at all?
I've had sarcoidosis, and
Right.
I don't know, because I'm on steroids, it's not too bad, the breathing.
Okay. But you're not sort of coughing, or you don't find that you're breathless when you exert yourself, or?
No.
Okay. Any problems with pains in the chest?
No.
Any palpitations?
No.
Okay, good. Any sort of nausea or vomiting at all?
No.
Good. And are your bowels moving properly?
Yes.
Okay. Any problems when you pass urine?
No.
Okay. And how's your mobility at the moment?
It's poor.
Okay. Can you walk up a flight of stairs?
I can, but it's got to be at my pace.
Okay, fine. And what medications do you take?
Methotrexate, prednisolone.
Mm-hmm. I'm assuming you're taking
rituximab.
Mm-hmm. Are you taking folic acid as well with the methotrexate?
Taking folic acid and omeprazole, I think it's called. Omeprazole.
Okay. And are you allergic to anything?
No.
Okay. Do you smoke?
No.
Have you ever smoked?
I have.
And how long did you smoke for?
Off and on. Don't think when I stopped, really. Probably 20 years.
Okay. How many did you smoke a day?
Up to 25.
Okay. And you drink?
Yes.
How much alcohol would you drink in a week?
Currently, probably less than 10 units.
Okay, fine. And is there any family history of problems with the joints?
My uncle had severe problems with his joints.
Okay. Was it sort of similar to the joint problems that you've got?
It must have been, yes.
Okay, that's fine. And, you know, I can see just from what you said about, you know, your ability to do certain tasks that this is affecting you quite a lot.
Yes.
Is there anything in particular that you're worried about with this?
I think it's not getting any better. Grip is a problem. Because other joints like the feet are affected, you can be a bit worried about falling. So there's quite a few things, really.
Yeah, so there's clearly a lot of things that are affecting you at the
Yeah.
moment. Okay. Yeah, I think you've absolutely done the right thing in coming to see me. Clearly the problems with the stiffness in your joints and the tiredness is affecting you. What I'd like to do now is examine you.
Okay.
So I'll have a proper look at your hands and any of the deformities, how the hands function. I'll have a look at your elbows and in your eyes, and then I'll have another chat to you about where we're going to go next. Okay, so what I'm going to do now is we're going to just have a general look at your hands first of all. Then I'm going to have a feel of the hands, feeling all of your joints. Okay.
Yep.
And then I'm just going to get you to do some movements.
Okay.
Okay. All right. So I'm just going to. Okay. Can I get you to turn the hands over for me, if you would? That's great. Thank you. So we've got a scar along there and a scar along there. Okay, turn the hands back over for me if you would. Just going to have a quick feel of the muscles now, alright? Alright, I'm just going to feel your pulses. Okay. I'm just going to have a feel of your joints now, all right?
Yep, fine.
I'm just going to ask you a couple more general questions as well. So, have you been able to work with
No.
where your hands are. And when did you retire?
About 20 years ago.
Okay. Is that tender at all?
No,
Okay. If it is tender, I want you to tell me.
I shall.
That's a bit tender there, is it?
Yep.
And that one?
That one definitely
Okay.
is, yeah.
Sorry, I'll be as gentle as I can be.
No. Yep, that one's tender. And this one was actually.
That one's tender
Yeah.
there as well. Okay, so that's 4 tender joints so far.
That one. That one's okay. Just a little bit.
Okay, so a number of the joints are tender there. All right. Fine. So I'll just have a quick feeling of your wrists as well. Are they tender there?
No, the right one's okay. The left one is.
It's tender there.
And swollen, yeah. Won't go
It's
away.
swollen, isn't it? Okay. Right. So can I just get you to do some movements now for me
Yep.
as well? So can you just make some fists for me? Right, and relax them back out for me. Good. Okay. Can I try and get you to make a prayer sign for me if you could? And can you try the other way for me if you can? Okay, so that's as far as it goes.
It is.
All right. I'm just going to test some of the first of all, the sensation in your hands. So I'm just going to.
Okay.
So if you just turn them back over for me, if you would. All right. So shut your eyes and let me know when you can feel me touching you.
No. 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 No.
Okay. Good. And now I'm just going to test some of the strength of the hand. So if you could just go like that for me. Keep them closed shut. Don't let me open them, all right? That's good. And we'll do the one. That's good. Now what I want you to do is just spread your fingers for me and don't let me push them in. Okay. So your strength's actually quite good in your hands there. All right. Next thing I'd like you to do is just hold the paper between 2 fingers if you could.
Any 2 fingers?
Any 2 fingers, it doesn't matter. And don't let me pull it away from you, all right? Okay, that's good. Good strength there. Okay, so I can see that you've got an abnormality on your elbow there. Is that tender?
No. Actually, it was, yeah.
Sorry, it's tender there.
Yeah.
Okay. And can I see your the rest of your elbows now? That's great. And are they tender there?
Just the right one.
Just the right one. Okay, you can relax for me. I'm just going to try and test the function of your hands as well.
Okay.
So could I just get you to try and pick that up for me? That's great. And with the other hand? Fantastic. Okay, so what I'm going to do now is just have a look at your ears and at your scalp, okay?
That's good.
And now what I'd like to do is just have a look in your eyes.
Okay.
So I know you said you've had a problem with your left eye, so that's probably the one I'll focus on.
Yep.
Could you just pull down gently on your eyelid for me, please? That's great. And can you just pull up on the left eyelid, on top eyelid as well, and look down for me? Fantastic, thank you. I think firstly, you've done absolutely the right thing coming to see me today. Clearly, the problems you're getting with the tiredness and the joints in particular is really quite debilitating. So there's some more tests that we need to do so that we can try and work out what's going on, and then I'll have another chat with you to explain where we're going to go next. So what I'm going to do is do an examination of the rest of your joints, your lungs, your abdomen, and then send you for some blood tests to see if you're anemic, and also some blood tests to see if there's any evidence of inflammation anywhere, which could be affecting the joints, and then we'll send you for some x-rays of the joints, and then we'll have another chat.
Okay.
Thank you.
Thank you.
So to complete my examination, I would like to take a full set of bedside observations, and I would like to do a full abdominal examination and an examination of the rest of the patient's joints.
Can you please present your clinical findings?
So this gentleman presents with a history of lethargy and significant joint pains. He has a deforming polyarthropathy, particularly present in the hands, with ulnar deviation of the fingers and subluxation at the wrists. This is in keeping with the diagnosis of rheumatoid arthritis.
Can you please list some extra-articular features of rheumatoid arthritis?
So rheumatoid arthritis does not just affect patients' joints, there are multiple organs that are involved. Firstly, in patients' eyes, they can develop a scleritis or an episcleritis. The particular severe form of scleritis that patients can contract is a scleromalacia, which I believe that this gentleman is suffering from, and the blue-grey discoloration that was seen on the sort of superior medial aspect of his left eyeball is likely to be a scleromalacia, though I would need to do a further examination of the eye to confirm this. Patients can also get a keratoconjunctivitis sicca as a result of rheumatoid arthritis. They can also have problems with their lungs, where patients can develop a number of rheumatoid nodules, and they can also develop a pulmonary fibrosis as a result of the rheumatoid arthritis. It's also important to say that treatment with methotrexate can also cause a methotrexate-related pneumonitis, which is commonly seen in patients who have rheumatoid arthritis. In the kidneys, patients can develop a nephrotic syndrome, and from that they can have a membranous glomerulonephritis, or they can develop renal amyloidosis. Patients have problems with their heart, where they can develop a constrictive pericarditis, or they can develop pericardial effusions. Patients can also have problems with their nervous system, where they can develop peripheral neuropathies, or they can develop carpal tunnel syndrome as a result of the subluxation at the wrist. Patients can also have problems with the spleen, where they develop splenomegaly, rheumatoid arthritis features, and they can develop a neutropenia, and this is called Feltes syndrome.
So you mentioned this patient might be anemic. What are the possible causes of anemia in a patient with rheumatoid arthritis?
So there are multiple potential causes of anemia in patients with rheumatoid arthritis. The first would be anemia of chronic disease. Patients can have iron deficiency anemia as a result of peptic ulceration from chronic long-term non-steroidal anti-inflammatory usage. Patients can have bone marrow suppression as a result of disease-modifying anti-rheumatic drug usage. And patients can also develop an autoimmune hemolytic anemia from the rheumatoid arthritis. Finally, patients can develop splenomegaly, which can cause an anemia as part of Felty syndrome, which I mentioned earlier.
You mentioned you would undertake x-rays for this patient. Can you describe some radiological features you might expect to find on x-rays in a patient with rheumatoid arthritis?
So there are multiple radiographic findings that can be seen in patients with rheumatoid arthritis. They can have soft tissue swelling, they can have loss of joint space with potential subluxation, they can also have periarticular osteopenia, and they can also be evidence of joint erosions.
Okay. Finally, how would you manage this patient?
So the management of rheumatoid arthritis needs to be through a multidisciplinary team approach. Patients often require the use of physiotherapists to help with their mobility, and occupational therapists to help them with tasks of daily living. This was evident in this gentleman, where he requires some adapted cutlery to help him eat his meals. From a medical perspective, Patients are usually require sort of urgent and rapid treatment with disease-modifying anti-rheumatic drugs, such as methotrexate or sulfasalazine. If patients fail to be well controlled with 2 different disease-modifying anti-rheumatic drugs, then they are often switched onto biological therapies such as rituximab or tocilizumab.
Okay, thank you. Rheumatoid arthritis is an important condition to be familiar with for the PACES exam. It is a chronic symmetrical autoimmune polyarthritis and is the commonest cause of chronic inflammatory polyarthritis with a prevalence of 1% in the population. And there is a strong genetic association with HLA-DR4. The American College of Rheumatology criteria defines rheumatoid arthritis in a patient as having 4 or more of the following features: morning stiffness for more than an hour, swelling of 3 or more joints, swelling of the proximal interphalangeal, metacarpophalangeal or wrist joints, symmetrical swelling of joints, subcutaneous rheumatoid nodules, presence of IgM rheumatoid factor, and radiographic erosions or periarticular osteopenia. It is important to have a systematic approach to the hand examination, which is a common feature of Station 5, and especially to be familiar with the features expected to be seen in patients with rheumatoid arthritis. On examination, there is a symmetrical deforming arthropathy, typically affecting the proximal interphalangeal and metacarpophalangeal joints. Presence of rheumatoid nodules at the elbows. There's also a number of deformities that can be seen in the hand, including palmar subluxation and ulnar drift of the metacarpophalangeal joints, swan neck or boutonniere's deformities, Z-shaped deformity of the thumbs, swelling and subluxation of the ulnar styloid. There may also be evidence of a carpal tunnel scar and wasting of the intrinsic muscles of the hands. Pain, swelling, stiffness, and restriction of movement of affected joints should be elicited. It is also important to assess function by testing pincer grip movements, for example, fastening buttons or picking up objects such as a coin from the table, or asking the patient to write a few words. Disease activity can be measured by various objective tools, such as the Disease Activity Score 28, which is based on a clinical assessment of the number of tender joints, swollen joints, global pain score, and a blood marker of inflammation, such as erythrocyte sedimentation rate or C-reactive protein. A Disease Activity Score 28 of greater than 5.1 implies active disease, and less than 2.6 is indicative of remission. Patients with rheumatoid arthritis often have extra-articular features, especially if they are seropositive for rheumatoid factor. For instance, in the eyes, they can experience episcleritis, which is typically painless, or scleritis, which is painful. Scleritis is associated with pain and redness affecting the sclera, which in severe cases can lead to permanent loss of vision. A rare form of necrotizing scleritis involves progressive thinning of the sclera without signs of inflammation, and this is known as scleromalacia perforans, which is what this patient had. This describes a degenerative thinning of the sclera, often associated with a blue-black discoloration, and that's caused by melanocytes in the choroidal layer of the eye becoming visible through the thin sclera. Treatment involves topical and systemic immunosuppression. Other eye manifestations include keratoconjunctivitis sicca, steroid-induced cataracts, and retinal vasculitis. In the lungs, patients can develop fibrosing alveolitis that can cause an obstructive lung disease. Other manifestations include pulmonary or pleural nodules, pleural effusions, pulmonary fibrosis, or pulmonary vasculitis. In the kidneys, patients can develop nephrotic syndrome due to membranous nephropathy or renal amyloidosis. In the nervous system, carpal tunnel syndrome can arise, or peripheral sensoromotor neuropathies as part of a mononeuritis multiplex, or in a glove and stocking distribution. Cardiovascular complications include constrictive pericarditis or pericardial effusion. And finally, Felty syndrome describes the presence of rheumatoid arthritis, splenomegaly, and neutropenia. With respect to blood tests, anemia is often present, and this is multifactorial typically. For instance, patients can be anemic as a result of anemia of chronic disease, iron deficiency anemia from peptic ulceration secondary to non-steroidal anti-inflammatory drug use, marrow suppression secondary to disease-modifying anti-rheumatic drugs, autoimmune hemolytic anemia can arise, and anemia can also arise as a result of splenomegaly in Felty syndrome. In addition to a full blood count, C-reactive protein and erythrocyte sedimentation rate is important to check as a biomarker of inflammation, along with key autoantibodies, which include rheumatoid factor and anti-CCP or cyclic citrullonated peptide antibodies. X-rays of joints will show soft tissue swelling, reduced joint space with or without subluxation, periarticular osteopenia, and joint erosions. With respect to management, a multidisciplinary team approach is important, which will involve members such as the occupational therapists, physiotherapists, pharmacists, specialist nurses, and rheumatologists. The mainstay of medical treatment rests on early use of DMARD therapy or disease-modifying anti-rheumatic drugs, really as soon as the diagnosis is reached. They have been shown to reduce progressive damage and improve prognosis. Methotrexate is typically the first-line treatment. This is taken weekly with folate supplementation. Side effects include anemia, bone marrow suppression, and liver toxicity. Therefore, regular monitoring of blood tests every 2 to 3 months is recommended once the treatment is established. If methotrexate is contraindicated, leflunomide, sulfasalazine, or hydroxychloroquine could be trialled. Thereafter, if patients fail to respond to 2 DMARDs, or if there are poor prognostic markers, such as positive rheumatoid factor, positive anti-CCP antibody, erosions present at diagnosis, very extensive active disease at onset, then a biological DMARD should be added. These include TNF-alpha inhibitors, such as adalimumab, etanercept, or infliximab, or other agents such as rituximab, which is an anti-CD20 antibody causing B-cell depletion, or abatacept, which is a T-cell co-receptor blocker. Steroids are advised as short-term bridging therapy when switching to a DMARD. Finally, surgical options include arthroplasty, arthrodesis, or synovectomy.
Good morning.
Good morning.
My name's Dr. Farrant. Can I just confirm your name, please?
Yeah, Marianne Gaskell.
Nice to meet you, Mrs. Gaskell. So what is it you come to see me about today?
I've got some pains and I've got a temperature. I don't feel very well.
Okay. And whereabouts are the pains?
They're kind of down, sort of around here.
Okay, just sort of all over your abdomen, really?
Yeah, yeah.
Okay. And how long have you had these sort of symptoms for?
2 or 3 days now.
2 or 3 days?
Yeah.
Okay. Sort of how often do you think you've been having temperatures for?
The temperature's only just started, which is why I've come to see you.
Right, okay. Have the pains always been just in the centre of the abdomen, or have they been worse in one part, or?
No, kind of just all over, really.
Just all over? Okay, that's fine. Have you had any sort of problems with your appetite at all?
A little bit, yes. Yeah,
been off your food a bit?
Yeah, yeah.
Okay. And what about, have your bowels been moving okay?
That's been all right, yeah.
Okay. And have you had any problems passing urine?
Yeah, it burns quite a lot, yeah.
Okay. And have you noticed any blood in the urine at all?
No.
Okay. And have you been going to the sort of to pass water more frequently?
Yeah, I have, yeah, because it burns and then I want to go and need to go quite a lot.
Okay. And have you noticed the urine's a bit more smelly than normal?
Yes, yes.
Okay. Is it sort of a normal, I know it's sort of not a nice question, but is it a normal colour or is it?
No, it's quite dark.
Quite dark?
Yes.
Okay. Fine. And do you get urine infections a lot?
I get them quite a few. Yeah, just lately I have.
You've
Yes,
had
quite
a
lot.
fair few of them. Okay. Just a few sort of more general questions. Have you had any sort of headaches or?
Not really, no.
No. Okay. Has your vision been all right?
Yes.
Okay. How about your breathing? Have you had a cough at all?
No, no.
Okay. Any pains in the chest?
No, just in the abdomen. Like
Just
I
in
say,
the abdomen. Yeah. Okay. Any palpitations or flutters in the chest?
No, no.
Okay. And have you had any weight loss recently?
Yeah, because I've not been eating that much.
Okay. Do you know how much weight you've lost?
A few pounds, I think.
A few pounds. Okay. And is that just over the last sort of couple of weeks, really?
Yes, yes, I'd say so. Yes.
Okay. And any weakness in your legs at all that you've noticed, or
no?
Any change in sensation at all?
No, no.
Okay. Good. And do you have any sort of medical problems that I should know about?
Yes, I do have kidney failure, yes.
Okay. How long have you had kidney failure for?
For a few years since I had a kidney transplant.
Oh, you've had a kidney transplant?
Yes, I have, yes.
Okay. And have you had any problems with the transplant since it was put in?
Not with the transplant, no, just with water infections
So it's
every now and again.
just sort of recurrent infections?
Yeah.
Okay. And is the transplant itself tender, do you think, at the moment? Or?
A little bit, yes.
Okay. Have you still got your normal kidneys?
Yes, I have, yes.
And are they tender as well?
They can be at times,
They
yes.
can be.
Yes.
Okay. Have you sort of noticed there's any sort of redness in the area where the transplant was or anything like that?
No.
Okay. And do you have any other medical problems that I should know about?
No.
Okay, so there's nothing else that you see your doctor for on a regular basis?
No.
Okay. What medications do you take?
If I can just give you a list rather than telling you, because I'm on quite a lot. Written it down.
Okay. So you're taking cyclosporin,
Yes.
doxazicin, ferrous sulfate, atorvastatin.
Yeah.
You're taking vitamin D, and then every 3 weeks you have erythropoietin injections.
The EPO, yes.
EPO, yes. Okay, good. And in particular with your cyclosporin, when did you last have your levels checked?
Well, they check them every time I go to the clinic, which
Okay.
is about every 3 months.
And have you had any problems with the cyclosporin levels?
No.
Okay. Have you noticed any sort of problems as a result of taking the medication?
Not really, only a little bit of pins and needles in my hands.
Okay. Have you noticed your hands shake at all or tremor?
Very, very slightly. It's nothing to mention, nothing to speak of, really.
Good. Okay. And any problems with your gums at all?
No, haven't.
Fine. Okay. So are you allergic to any medications?
No.
Right. And do you smoke?
No.
Have you ever smoked?
No.
Good. Do you drink any alcohol?
Occasionally, yes.
Okay. How frequent is occasionally?
A couple of times a week, a glass of wine.
Okay. Is there any family history of any sort of medical problems?
Well, my dad had kidney failure too.
Okay, fine. That's important to mention. I think
Yes.
when I examine you, then that may be something we need to talk about in a little bit in more detail. But I'll examine you first. Do you have anything in particular that you're worried about?
Well, obviously I'm worried that the pains that I'm getting might be affecting my transplanted kidney, you know, because that would be terrible.
And I think that's a really valid concern. It's clearly, it's a big thing.
Yes, it
having
is.
a transplant put
Yeah.
in. And it's got to be of utmost importance that we take care of that transplant. So what we'll do is when I examine you, I'll pay a lot of attention to the transplant just to make sure that I can't see any signs that it might be failing. All right.
Yeah.
Have you noticed any sort of problems like leg swelling at all, or?
No, I haven't.
Okay, and you said that it was a bit tender over the transplant. Okay,
yes.
But it's not sort of become or anything like that.
No.
Okay, good. So what we'll do now, we'll get you on the couch, okay, and I'll give you a thorough examination. Particularly, I'm going to look at your abdomen and pay a lot of attention to the transplant that you've had, and then also I'll just examine other parts of your body just to make sure that there's no problems from the medication that you're taking as a result of the transplant.
Yeah.
Once we've completed all of that, then I'll have another chat to you about any further tests that we need to do and where we're going to go from next. So what I'm going to do now is just have an examination of you, all right? So I'll have a general look at you first, and then I'll have a look at your hands, your face, your eyes, and then I'll have a proper focus on your abdomen. What I'd like you to do first of all is just lift up for me just so that I can see your abdomen. We can just, that's great. Okay, and I'll just have a general look at you. Okay, just take a nice deep breath in for me, please, and out. And give me a cough. Great. We'll just cover you back up now. And I'll have a look at your hands now, please. Turn them over for me. And keep them out there like that for me if you would. Okay. And if you just cock your wrists back for me like that, that's great. Just hold them there a little longer. Great. You can relax that other hand down now if you would. I'm just going to have a quick look at your pulse for a second. Okay. I'm just going to have a look at your arms now, if that's all right. Yeah. So we'll just pull those up. Okay. Okay, can I have a look at the other arm as well, please? That's great. We'll pull your sleeves down now as well. There you go. Just going to have a look at your neck now, okay? Do you have any pain in this part of your abdomen?
Yeah, that's where I have the pain, yeah.
Okay, I'm going to press on it, but just gently, all right?
Yeah.
Okay. I'm just going to feel the pulse in your neck for a second. Okay. Could you just pull down on one of your eyelids for me now, please? You can, yeah. That's great. Do you want to sit your glasses back on? Can you just open your mouth for me now, please? And let me see the bottom of your tongue now, please. Perfect. Okay, could you just pull down on your bottom lip so I can see your gums as well? That's great. I'm just going to have a look at the top of your chest now, if that's okay. You've got a bit of a rash on your neck here.
Yeah, yes I have. Got ointments on it at the moment.
Okay. Is that related to your kidney problem, do you think?
I'm not sure. I don't know what it's related to. It does flare up every now and again.
Okay. What I'm going to do now is just get you to sit forward for me if you would. And then I'm just going to lie the bed down flat. Okay, so I'm just going to have a general look at your abdomen now, if that's all right.
Yeah.
So if we could just uncover for me. That's great. Okay. Right, so I'm just going to have a general look at things. So I know your abdomen's tender in this sort of area. Okay, I need to have a feel of everything. If it's too tender, just let me know, all right? That's where it's tender, is it?
Yeah.
Okay. And that feels like your kidney underneath there, the transplant kidney.
Yeah.
Is that tender there to press?
No, it's all right. That.
Good. Nice deep breath in for me. And out. And in. And out. And in. And out. And again. And out. And again. And out. And again. And out. And again. And out. All right, can you just roll towards me slightly now, please, and back down. Okay, and could you roll the other way for me, and back down. Okay, just gonna have a listen now. Just going to have a look at your legs now. Okay, so let's sit you up. I think you did absolutely the right thing in coming to see me today. Clearly, you know, the fact that you've got a transplant and it sounds like you've probably got an infection down in your bladder, which, you know, has a risk of going to the transplant. So you've done the right thing, because what we need to do now is get you on some antibiotics intravenously, get you on some fluids as well, and then we're going to do some blood tests, and we're going to take a sample of your urine, and we'll go from there.
Yeah.
All right? Any questions that you want to ask?
No.
Thank you. So to complete my examination, I'd like to do a full set of bedside observations, and I'd like to do a urine dip.
Can you please present your clinical findings?
So I believe that this patient has end-stage renal failure. The underlying etiology for that I believe to be polycystic kidney disease, and her current mode of renal replacement therapy appears to be via a transplanted kidney in the right iliac fossa. The positive clinical findings that have led me to this diagnosis are that she has evidence of a mass underlying a Rutherford-Morrison scar in the right iliac fossa, and she also has two large masses in the central aspect of the abdomen, which are both blottable, which I believe are the polycystic kidneys. Concurrent to her long-term diagnosis of end-stage renal failure, she presents with a history of suprapubic tenderness, pyrexia, dysuria and polyuria, which I believe is likely to be an underlying urinary tract infection.
Okay. What is the inheritance pattern of polycystic kidney disease?
So polycystic kidney disease is inherited in an autosomal dominant fashion, and there are two main genes which encode for polycystic kidney disease. The first is the PKD1 gene, which accounts for approximately 85% of patients with polycystic kidney disease. The second is the PKD2 gene, which accounts for approximately 15% of patients.
So if a patient with polycystic kidney disease reported loin pain, what would your differentials be?
So there are multiple differentials for loin pain in a patient who has polycystic kidney disease. The first would be cyst rupture, cyst hemorrhage, patients with renal stones, enlargement of cysts, or potential kidney infection.
What are the extrarenal manifestations of polycystic kidney disease?
So there are multiple places that patients can have an extrarenal manifestation of polycystic kidney disease. Importantly, patients can develop cysts within the liver and develop polycystic liver disease. Also, patients can develop a aneurysm within the brain, berry aneurysms, and any signs of patients who have a subarachnoid hemorrhage need to be screened for polycystic kidney disease. Also, patients can develop a mitral valve prolapse, and that's present in about 25% of cases of patients with polycystic kidney disease.
So this patient's form of renal replacement therapy was via transplant.
Mm-hmm.
What other forms of renal replacement therapy are you aware of?
So there are two other forms of renal replacement therapy. The first is via hemodialysis, and I assess this patient's arms to look for evidence of an arteriovenous fistula, which is the mode in which we use hemodialysis, and there was no evidence of that, so I don't believe that this patient has previously had hemodialysis. The other form of renal replacement therapy is peritoneal dialysis, and this lady had a central scar extending from below the level of the umbilicus, which I think is in keeping with previous peritoneal dialysis.
What are the complications of immunosuppressive therapy?
So the complications of immunosuppressive therapy can be split into two categories. The first is the complications of actually being on immunosuppressive therapy, and the second will be the complications of immunosuppression itself. The complications of immunosuppressive therapy, and in this patient's case she was on cyclosporin, would be gum hypertrophy, a tremor, hypertension, and diabetes. Complications of immunosuppression itself would be opportunistic infections and also malignancies. In particular, patients who are immunosuppressed can suffer skin malignancies, which are most prevalent on sun-exposed areas. On assessment of this patient, I couldn't see any evidence of scarring on her sun-exposed areas, so I don't think at present she is suffering from a skin malignancy. She did have evidence of a rash across her neck, though I think that's unrelated to this condition.
Do you know of any medications that can be used to retard the progression of polycystic kidney disease?
So there is a NICE approved medication called tolvaptan, which is used to slow the progression of polycystic kidney disease.
Okay, thank you. Polycystic kidney disease is an autosomal dominant condition characterized by the development and growth of multiple cysts within the kidneys. It is the most common inherited kidney disease, affecting 1 in 400 to 1 in 1,000 live births. It affects both sexes equally and occurs across all ethnicities. There are two main causative genes: PKD1 on chromosome 16, implicated in 85% of cases, and PKD2 on chromosome 4, implicated in 15% of cases. There is significant phenotypic variation even in families with a history of polycystic kidney disease, but PKD2 mutations tend to have a milder expression of disease with smaller volume kidneys and later onset of end-stage renal failure. PKD1 gene produces polycystin 1, and failure of normal polycystin formation results in aberrant signaling between cells, resulting in abnormal cell division, leading to cyst formation. Cysts arise from all segments of the nephron and collecting ducts. As they grow, they dissociate to form isolated fluid-filled sacs. Clinical features can be split into renal and extrarenal manifestations. Renal features include polyuria or nocturia, caused by a urine concentrating defect, which is often an early sign of polycystic kidney disease and often preceding cyst formation. Hypertension is the most common manifestation and is associated with progression of renal decline and cardiovascular morbidity and mortality. Patients can experience loin pain for which there are multiple causes: hemorrhage, infection, renal stones, or increased size of the cysts causing renal capsule stretching. Finally, patients are at risk of progression to end-stage renal failure with a mean age of onset in the late 50s in those with PKD1 mutations. Extrarenal manifestations are also common. The most common is liver cysts. Most patients are asymptomatic from this, and liver dysfunction is not common, although with increasing size, symptoms of abdominal pain, gastroesophageal reflux disease, and early satiety can arise, as well as complications associated with cyst rupture, infection, and hemorrhage. Cysts can also arise in the pancreas, spleen, and ovaries, and arachnoid cysts can also develop, but these are all typically asymptomatic. Mitral valve prolapse is also present in about 25% of patients. Intracranial aneurysms are also associated with polycystic kidney disease, and there's a higher risk of occurrence in those with a positive family history. The mainstay of investigation is with imaging. In those patients without a family history of polycystic kidney disease, bilateral enlarged kidneys with 10 or more cysts in each kidney makes polycystic kidney disease very likely. Where there is a family history, diagnosis is dependent on the age of the patient and the number of cysts in each kidney. In equivocal cases, genetic testing can be undertaken. With respect to management, tolvaptan, a vasopressin 2 receptor antagonist, has been approved by NICE to slow the progression of cyst development and progression to end-stage renal failure in patients with polycystic kidney disease, but there are specific criteria for its use, which includes patients having CKD stages 2 or 3 with evidence of rapidly progressive disease. And rapidly progressive disease is defined as more than 2.5 mils per minute per year eGFR loss with 5 points over 5 years, or more than 5 mil per minute eGFR loss over 12 months. Along with tolvaptan, a key aspect of management lies with good blood pressure control. And for those that reach end-stage renal failure, renal replacement therapy is required, with the best outcomes seen in those who receive a preemptive renal transplant.
Good morning.
Hello.
My name's Dr. Farrant. Can I just confirm your name, please?
Yeah, my name's Adam.
Nice to meet you, Adam. What is it you've come to see me about today?
I've been having some difficulty walking. It feels like my lower legs are getting weak, so some difficulty standing, some difficulty climbing stairs, difficulty walking sometimes.
Okay. And how long has this been going on for?
That I've really specifically noticed about 5 years, but I think probably about 10 years thinking about things like I can't jump.
So they're weak all the time, are they?
Yeah, it doesn't come and go. It's all of the time. Yeah.
Okay. So talk me through the things that you're sort of struggling with day to day.
I walk to and from work every day, about 20 minutes. And if I come to a traffic light, to a pedestrian crossing, in order to stay where I am, I have to hold on to the railings. If I'm going upstairs, I have to hold on to the banister to keep me steady and to help me propel myself upwards. I have started to use a stick to stay standing still. So if I'm stood talking to someone, it means I don't have to hold on to a wall. Okay. I can just use that.
And what would happen if you didn't have the stick?
I would have to walk backwards and forwards to stay standing upright. I wouldn't be able to stand on the spot still.
Okay. Clearly this is, something that's affecting you quite a lot. So is there any sort of problems with sensation in the legs, or is it just weakness?
Not that I've noticed. It just feels weak. I've not noticed any lack of feeling at any point. No.
Okay. And is it worse at any particular time of the day?
Potentially in the morning. Just getting out of bed, but not by much. It's pretty consistent throughout the day.
Okay. And does it get worse the more sort of exercise you do, would you say?
On the day that I have done exercise, yes. But if I do regular exercise over a period of time, it does feel like it's getting a bit better.
Okay. And you said that sort of climbing stairs was difficult because you need to hold on to the banister.
Yeah.
Do you climb stairs at sort of a normal speed to somebody else, or does it take you a lot longer?
I'd say probably about half the speed. It takes me twice as long to climb up a set of stairs as it would the average member of the public.
Okay. And how are you sort of standing up from chairs and things like that?
There is some difficulty. I would have to use my hands in order to comfortably get up from a seated position.
Okay. Clearly that, is affecting your legs quite a lot. Have you noticed any weakness in your arms at all?
Not particularly. Some weakness with my fingers. So if I'm carrying shopping bags and there's a lot of shopping, it can feel like they might be about to slip from my fingers, but not other than that.
Okay. And sort of, is there weakness in your feet as well, or is it mainly your legs that you sort of noticed?
Not any weakness. I've noticed that I can't move my feet. So if I were to lift my foot there, I'm trying to pull it upwards, and it's not.
Okay.
And if I try and push it downwards, it doesn't go downwards.
Okay, so it's just.
But my toes, I can move my toes at the end of my feet. I just can't move my foot itself.
Okay, and is it the same on both sides?
Yeah, exactly the same. So I can move side to side, but I can't move up or down.
Okay. Is your balance all right?
My sense of balance is fine, other than needing to walk back and forwards to stay still, as it were, or use the stick. But I don't feel wobbly at any point, sort of within my ears.
Okay. And any visual problems at all?
Not that I've noticed. No.
Do you ever notice that your eyelids droop or anything like that?
No.
Okay, that's fine. Is your speech all right?
As far as I can tell, I've not noticed anything.
No one's told you that you're slurring your words or anything like that?
Not to my face, no.
Okay, that's fine. Any breathing problems at all?
No.
Okay, are you all right lying flat?
Yeah.
You don't need to prop yourself up with multiple pillows
Oh,
overnight
I see.
or anything like that?
No, that'd be fine. Yeah.
Okay.
Yeah.
Any palpitations or chest pains or anything?
Not that I've noticed, no.
Good. And are your bowels okay?
Yeah.
Any nausea or vomiting?
No.
Okay. Any bladder problems?
No.
Okay. Good. And when you actually open your bowels, can you feel everything coming out? Is it?
I've not thought about it, but yes, I guess I can. Yeah.
And when you're passing passing urine, can you feel the stream?
Yeah.
Okay. Good. Do you have any sort of other medical problems at all?
Nothing. I used to wear glasses, but I've had laser eye surgery. But other than that, as far as I'm aware, I'm completely healthy.
Okay. And are you allergic to anything?
Again, not as far as I know.
Okay. Do you take any regular medication?
I don't. Not currently.
Okay. And is there any sort of history of any conditions that run in the family at all?
No. So, all of my grandparents walked with a stick once they got to sort of pension age, but other than that, no one's had any sort of
similar
weakness. Exactly.
Okay. Yeah. Fine. Right. And there's no problems with anybody sort of dying young in your family, or
the only person that has so far, it was a form of cancer. So
okay.
Other than that, no.
Fine. I know that's a bit of a morbid question to ask, but it's important that we ask those things. Okay. And do you smoke at all?
No.
Have you ever smoked?
Maybe a cigarette's worth throughout my life at some point, but
okay.
Yeah.
Fine. And do you drink any alcohol?
Again, I've had maybe 2 pints this year, something like that, but not with any regularity.
Is that just because you're worried about your balance and all those sorts of things? Would you say?
Partly, I guess a moral decision, but also I'm already wobbly enough on a day-to-day basis that I don't need to add to that.
Yeah, that's fair enough. Okay. Have you had any problems at work with this, or?
Only in that I've noticed that it's useful to have my stick with me for if I'm standing to someone, standing talking to someone, that then I can stay still rather than
having to walk up and down.
Back and forwards,
Okay.
exactly. Yeah.
That's fine. Right. Okay. And you know, what is it you're particularly worried about with this at the moment?
I'm worried that it's something serious and it might get worse, and that I don't know what it is. I don't know whether I'm imagining it or whether it is actual muscle weakness. You know.
Okay. So firstly, I think you've done absolutely the right thing. You know, if you're concerned about something, clearly there's something that's not quite right. It's something that we need to do some more investigations into. So what I'd like to do now, first of all, is have a look at the way you walk, and then we'll get you on the couch and I'll have a proper examination of your legs and anything else that might be relevant. And then we'll talk you through what I think are the things that could be going on, and then the further investigations that we're going to need to do following that to try and give us a better idea of exactly what the cause of your problem is. Is there any other questions you want to ask?
Not at this point.
Okay, so what I'd like you to do now, if possible, is just to walk up and down for me, just so I can see the way that you walk. If you're going to be comfortable doing it, I'd like you to do it without the walking stick. If you're finding it really difficult, I'll come and help you and give you the walking stick back. All right?
Yeah, that's fine.
Okay. Okay. What I'd like you to do now, if possible, is for you just to try and stand on your tiptoes, if you could.
Okay. I can't. I can do that.
Okay.
But I can't.
That's fine. But you can't actually go up. And that's it. It's the weakness in the muscles that's causing that to be the issue. Okay. Fine. So what I think we should do now is get you on the bed so that I can examine your legs in more detail. All right?
Yeah.
Okay. So what I'm going to do now is I'm going to have a look at your legs. Just sort of look at the sort of the tone of the legs. Then we'll do some movements, and I'll just check the strength of your legs. All right. We'll check how the sensation in your legs, and then I'll just check your reflexes at that point. Okay. All right.
Yeah.
So have you got any pain in your legs at all at the moment, or?
No.
Okay. Good. I'll just have a general look at them first. Just relax yourself back for me, if you would. Just let your leg go nice and floppy for me now, if you would. Okay. Right. So what I'd like you to do now is just try and lift this leg up straight for me, if you could. And just hold it there for me. Hold it there for me. Now don't let me push it down. Okay. And the other one, hold it there for me, hold it there for me, don't let me push it down. Okay, so it's clearly difficult for you there, all right? Could you try and bend that knee for me now, if you could? Okay. And then what I want you to do is just try and kick out against my hand. Okay, and try and pull your ankle in towards your bottom. Okay. So it's clearly difficult there, isn't it? Okay, we'll just do the same on the other side. So if you could bend that knee for me, kick out against my hand. Okay, and pull your ankle into your bottom. Okay, and relax your leg down for me. Okay. What I want you to try and do now is just push down against my hand. And push down against my hand for me. Push up for me if you could. And push up for me if you could. Okay. Just push down with your big toe for me if you could. With your big toe, push down for me if you could. Okay. So what I'm going to do now is just have a touch of your legs and just check your sensation. So what I'd like you to do is just close your eyes for me. Okay. All right. And then what I want you to do is just tell me when you feel something touching your leg. Okay. All right.
Yeah. 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 Yeah.
Okay. I'm just going to do the same with this with this pin, all right? So eyes closed again.
Yes. 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 Yeah. 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 Yeah.
Okay. Okay. So what I'd like you to do now is just bend that knee slightly for me. Just go nice and relaxed. Okay. Just let the leg go nice and floppy for me. Okay. Okay, and relax. Bend that knee for me. Just keep it nice and floppy for me. All right. Okay, and when that's done, and just let your leg roll outwards for me. Same on the other one, nice and relaxed. Okay. Okay, just going to tickle the bottom of your feet now, okay? Okay, so I'm just going to test the coordination in your legs now, all right? So what I'd like you to do now is just take your heel of your ankle and place it on your knee for me, and then run your heel down your shin to the bottom of your foot, up and then back to your knee and down. Just do that a few times for me if you would. Okay, and can you do the same on the other side now for me, please? Okay, that's great. Firstly, I think it's really important that you've come and seen me today. You've done absolutely the right thing. Clearly, the weakness in your legs is there, and I can see that on the examination.
Yeah. And
it's something that's clearly having quite a profound impact on your life and the way that you go about all your sort of normal daily tasks. So I think it's something we should investigate in more detail.
Okay.
All right. So I'm going to refer you on to one of the neurology specialists. Okay. And I think we should do some tests, some more sort of specialist tests of the nerves, what we call some nerve conduction studies, and maybe a muscle biopsy.
Okay.
All right. And I think it'd be a really good idea for us to spend a bit more time speaking to you about your family history and whether there's any sort of things that could be causing a genetic link, which might lead us to the underlying diagnosis.
Cool.
All right.
Yeah.
Is there anything else that you want to ask me about today?
No.
Okay. Thank you. So to complete my examination, I would like to perform a full upper limb neurological examination and a cranial nerve examination. Okay. Thank you.
Can you please summarise your findings?
This patient presents with a prolonged history of significant lower limb weakness, which is causing a significant impact on his ability to carry out tasks of daily living. He has difficulty with walking, difficulty with standing for any prolonged period of time. He also has difficulty getting up from a seated position and difficulty in climbing stairs. He also reported that he had difficulty with his grip strength, as well as difficulty with the lower limbs. On examination, he had a symmetrical, predominantly distal lower limb weakness. There was weakness of the knee extension and flexion, more so than at hip flexion, and it was even worse with movements of the ankle in both plantar and dorsiflexion. Those movements were almost absent. There was also preservation of the knee jerk reflexes, but absent ankle jerk reflexes. The patient's sensation was intact, and there was normal coordination. Also to note that the patient had evidence of potential foot drop, with the difficulty with dorsiflexing the foot being in keeping with this. Those findings, I believe, are consistent with a diagnosis
of muscular dystrophy, particularly given the patient's age and the history.
What type of muscular dystrophy do you think this patient has?
There are a number of different types of muscular dystrophy. These can include Duchenne's muscular dystrophy and Becker's muscular dystrophy, though I think in this case those two are unlikely. The reasons for that are, firstly, the patient's age. He appears to be in approximately his mid-20s and is still able to walk, and a patient with Duchenne's or Becker's muscular dystrophy would be having significant difficulty with that at this age. Also, the distribution of this gentleman's weakness makes a facioscapulohumeral dystrophy unlikely, as that condition predominantly affects the arms and the shoulders. I therefore think that this is most likely to be a limb girdle muscular dystrophy. To elicit the exact type of a limb girdle dystrophy, I would need to do some further tests.
So how would you investigate this patient?
There would be a number of investigations that I would like to do. Firstly, I'd like to do a further examination, like I've said, to examine the patient's upper limbs and cranial nerves. I would then like to refer the patient for nerve conduction studies. Given my concern about muscular dystrophy, I think it would be appropriate for us to refer him for a muscle biopsy, and also refer him for some genetic screening to see if there is any underlying genetic defect which may encode for the type of muscular dystrophy that this patient, I believe, is suffering from.
How would you manage this patient?
The management of muscular dystrophy is predominantly in a multidisciplinary approach. Patients can require help from the physiotherapists to help them with their walking, and they can also require help from the occupational therapists. Particularly in this gentleman's case, he requires a walking stick, so the physiotherapists may need to help him with that, and then particularly when his walking, or if his walking gets worse, he may require further assistance from the physiotherapists. Also, he requires banisters when walking upstairs, and he may require an assessment from the occupational therapist to see if any modifications are required in his home. At present, there aren't any specific sort of pharmaceutical therapies available for the treatment of muscular dystrophy, and therefore it's more of a multidisciplinary approach that I would require to, or I would suggest that's used in this patient's case.
Thank you.
Thank you.
The history of progressive limb weakness with an onset in earlier life, allied to a focused limb examination, should help you consider muscular dystrophy in your differentials. A positive family history will help, but there may not be a family history, as in this case, if the condition was inherited in an autosomal recessive fashion. Muscular dystrophies represent a large group of disorders characterized by progressive weakness of the skeletal muscles. Examples include Duchenne muscular dystrophy, Becker's muscular dystrophy, oculopharyngeal muscular dystrophy, myotonic dystrophy, facioscapulohumeral muscular dystrophy, and limb girdle muscular dystrophy. It can be helpful for the PACES exam to have some familiarity with respect to the distinguishing features between these conditions. Limb girdle muscular dystrophies are a group of inherited muscular dystrophies characterized by progressive weakness of the shoulders and pelvic girdle muscles. It has a variable phenotypic presentation depending on the specific type of dystrophy. This patient specifically had limb girdle muscular dystrophy type 2B. Here, patients are affected by weakness and wasting of the shoulder, hip, thigh, and calf muscles. The history may reveal difficulties with raising arms as a result of shoulder weakness. Distal weakness will cause problems with mobility, especially walking, running, getting up from a sitting position, jumping, and climbing upstairs. The candidate did well in this case in gaining the history and also exploring the impact of the condition on the patient's activities of daily living. In addition, the candidate's examination was well focused, assessing the patient's gait, eliciting foot drop, inspecting for muscle wasting, and confirming lower limb weakness. Management, as is the case with all forms of muscular dystrophy, involves a multidisciplinary approach to meet the needs of the patient, especially with respect to providing support for any physical impairments the patient may have.
Good morning.
Morning.
My name's Dr. Farrant. Can I just confirm your name, please?
Yeah, it's Ian.
Nice to meet you, Ian. So what is it you've come to see me about today?
I had a crash about 6-8 months ago, quite a high-speed crash, and after about 4 or 5 months started getting a shake in my right arm, so I thought whether trapped something in my neck or damaged something.
Okay. And is it just in your right arm that you're getting the tremor, or are you getting it in your left arm as well?
Just my right arm.
Okay. And is that tremor present throughout the day, or?
It's mainly when I'm resting. If I'm doing something, it's fine, but when I stop and relax, it sort of sets itself off a little bit. Or if I get a bit of pressure or something, it starts shaking.
Okay. And is it there at night as well?
It's there pretty constant, really. Apparently it doesn't do, when I'm asleep it doesn't do it, but obviously that's what the wife tells me.
Okay. And have you noticed any sort of other symptoms, like is your arm getting stiff at all? Is your neck getting stiff, or?
My arm, it does feel a little bit stiffer than it used to do.
Mm.
And I've also started getting a bit of pain down the back of my hamstrings.
Mm. Okay. And has that been affecting your walking as well?
It can do, yeah. Particularly in the morning. If I take the dog out and I have to bend down to do anything, I have trouble sort of getting down to do what I'm doing.
Mm. Okay. And is your balance affected with this at all, or?
Balance is fine.
Okay. And what about sort of when you're having to do anything at home with the tremor? How is it sort of affecting your ability to do tasks and things?
It's not too bad, to be honest. If I'm doing, I can do little tiny things and it's fine as long as I'm concentrating on what I'm doing.
Mm.
But if I just sort of relax for a minute, it sets itself off shaking again then.
Okay. How about sort of, eating and things like that?
Tea time, yeah. It tends to sort of start shaking when I'm having my tea. I don't know why, but if I get hold of a spoon or a fork, it sort of sets off.
Mm.
But once I've finished, it goes back to sort of pretty much normal again.
Okay. So I imagine sort of, drinking liquids and things like that must be a bit more difficult for you.
It can be, yeah.
Okay. And what about writing? How's that been affected?
My writing's gone a lot ssmaller than it used to be, and it's a lot more scrawly, so I try and avoid writing really now.
Okay. And you said that the tremor's not there in your sleep. Are you having any sort of other sort of disturbances with your sleep at all, or?
No, sleep's fine.
Okay, good. And has this affected your mood at all?
Apparently I'm a bit grumpier than I used to be, a bit more agitated, and I can get a bit anxious.
Okay. And any sort of problems with dizziness at all, or?
No.
Okay, good. Any problems with your vision at all?
No, other than wearing glasses, no.
Okay. And are you working at all with this at the moment?
No, I retired. I was in the police, so shortly after I had me crash, I was due to retire anyway. So.
Okay. So the tremor isn't the thing that's led you to retire. It's more
No,
the crash that you had.
Yeah.
Okay. And you said sort of you had the crash and then you got the stiffness in your neck first of all.
Yeah.
So has that all now settled down and it's just the tremor that's left?
My neck's still a little bit stiff, but it's nothing like it used to be.
Okay, so you can move your head around and all those sorts of things. Yeah. Okay. And what about pains in your shoulders at all? Are you getting any pains there?
Nothing.
That's fine. So there's no sort of weakness in your shoulders or anything that you've noticed? Just the tremor in your arm? Okay. Fine. And do you have any other medical problems that I should know about?
I've got arthritis in my spine, at the base of my spine.
Okay.
Bit of arthritis, spondylitis in my neck.
Okay.
That's about it, really.
Okay. And are you on any regular medication at the moment?
No.
Good. What about any allergies to anything?
No, I'm not allergic to anything as far as I know.
Okay, good. And then how about, are you smoking at the moment?
Never smoked.
Good. And what about alcohol?
Yeah, I had probably 5 or 6 pints on a Tuesday, maybe the same on a Friday.
Okay. And is that just sort of normal strength lager or?
Yeah, yeah.
Okay. So just a few more sort of general questions now. You mentioned that your vision was all right.
Yeah.
So is that, you're not getting any sort of blurred vision?
No, it's fine.
And you're not getting any double vision?
No.
Good. Are you getting any headaches at all?
No.
Has your hearing been all right?
Yes.
Okay. And has your speech been okay?
Sometimes I struggle to get a word out. I'll know what I want to say, but it just doesn't appear.
Okay. And how's your breathing been?
Breathing's fine.
No coughs, no phlegm or anything like that?
No.
Good. Any pains in your chest?
No.
Palpitations at all?
No.
Good. And are your bowels all right?
Fine.
Any nausea or vomiting?
No.
Okay. And any problems with your bladder at all?
No.
Okay, good. And obviously you've got the tremor, but is there any sort of weakness or numbness in any of your limbs that you've noticed?
Just my toe.
Okay.
My big toe. It gets numb in the morning on the outside, and then as the day goes on, it comes back again.
Okay. And how long have you had that for?
I've only noticed it about the last sort of 3 or 4 months.
Okay. And you'd said that you had some problems with your back as well. Yeah.
Yeah. I burst 2 discs probably 15 years ago.
Okay.
And I had my disc skimmed.
Right. So it may be that's that the toe's related to that, but it's something we can certainly examine in a bit more detail.
Okay.
All right. And just a few more questions. So obviously we'd mentioned that eating was difficult, but how you were sort of washing yourself and dressing yourself at home?
Fine.
Okay. So do you have any problems with buttons, doing them up and things like that?
No.
Great. And what about driving? Has that been an issue for you? Or?
No, it's fine.
Okay, good. So obviously, clearly you're concerned about the arm, and that's why you've come to see me. Is there anything else that you're worried about today?
Just the progression of it, really. It's starting to get a little bit worse, and I struggle with a fork and a spoon when I'm trying to eat.
Okay. That's clearly something that's worrying you, and I think it's important now for us to go on and try and understand what's causing all of this, and then we'll talk about ways that we can try and mitigate that for you.
Okay.
So, I think you've done absolutely the right thing in coming to see me today. All right. There's a number of things that I think might be going on, but what I'd like to do first, before I go into those, is to do a proper examination of you. Okay. All right, just so that I can try and get a better picture of sort of the test that we need to do next. So, what I'd like to do first of all is get you to stand up and just walk up and down, so I can have a look at the way that you're walking.
Okay.
All right. And then I'll do some tests to have a look at your arms, have a look at the tremor that you've been getting, okay, see if there's any stiffness in your limbs, and then I'll do some more specialised tests just to check your nerves in a bit more detail.
Okay.
All right. Once we've done that, then I'll sit down with you and I'll talk you through the further tests that we're going to send you for and what I think might be going on, and then we'll go from there.
Okay.
Is there anything else that you want to ask me about before we do that?
No, it's fine, thanks.
Okay, thank you. Okay. So what I'd like you to do now is just walk up and down for me, if you would, please.
Okay.
Great. And now, if you could just stand in front of me, but face that wall for me, please. I'm just going to pull back sharply on your shoulders, all right?
Yeah.
Have you got any pain in your shoulders?
No.
Okay. Great. Okay, so if you can just face me. So what we'll do now is we'll get you sat back down on the chair, and then I'll do a bit more of a detailed look at your nerves. All right?
Okay.
Okay, can I just have a look at your hands now, please? Turn them over. And just be relaxed, nice and relaxed for me now. Okay, can I just have your hand now? Just hold mine. Okay, what I want you to do with that hand now is just tap it on your leg for me if you would. Okay, and relax. And can I just have this hand now? Okay. And what I want you to do with the other hand is the same thing, just tap it up and down on your leg for me if you would. Okay, fine. So now what I'd like you to do is just have a look at my finger if you would for me, and just follow my finger with your eyes, but try and keep your head still for me if you would, okay? Did you have any changes in your vision when I did that?
No.
Okay, good. So what I'd like you to do now is just go like this for me if you would. Just keep doing it for me until I say stop. Okay, and relax for me now. Okay, so what I'd like you to do now is just touch your nose with your finger for me, please. And then touch my finger. And go backwards and forth for me. Okay, and with the other hand now.
Okay.
That's great. All right, so now what I'd like you to do is just put one hand out like that for me if you would, and then the other hand on top, and then I just want you to go like that for me now if you would. Quick as you can for me. And other hand now if you would. Okay, that's great. What I'd like you to do now for me, okay, is just write the line, I've come to see the doctor today. Okay, thank you very much. So, that's all the tests that I'd like to do. And I have a good idea about what I think is going on. All right. Now, it may well be that this is all related to the accident that you had, and the tremor is just as a result of some irritation of the nerves in the neck.
Okay.
Though I think it's unlikely. All right. What I think is more likely is that this is a potential form of Parkinson's that you might have.
Right.
All right. The reason for that is you're exhibiting a number of the different symptoms which would suggest that this might well be Parkinson's.
Okay.
Okay. Now, in order to confirm that, there's some more tests that I think we should do. All right. And there's a few more examinations that I'd like to do as well. Okay. So I'm going to send you for some blood tests, and I'm going to send you for a CT scan and an MRI scan of your head and also your neck.
Right.
Okay. Once we've got those tests done, I'll come back and have another look at you, and we'll have another discussion, and we'll go from there. All right.
Yeah.
If this is Parkinson's, all right, there's lots of treatments that are available, so we can give you some medication to try and help get on top of your symptoms. And we also have physiotherapists and occupational therapists who can help you, one with exercises, and the occupational therapists can help you with things to make life a bit easier for you at home. So we can give you different types of cutlery to help with the eating and the drinking issues that you've been having. We can give you other helps as well going forward. All
Okay.
right. Are there any other things that you want to talk to me about today?
No, it was just that really.
Thank you. So to complete my examination, I would like to perform a mini mental state examination and a lying and standing blood pressure. Thank you.
Can you please present your findings?
So this patient presents with a 6-month history of a unilateral tremor in his right hand following a road traffic collision. Though given the other symptoms which are present on and other findings on examination, I think the road traffic collision is insignificant in this case. The findings on examination that have led me towards my diagnosis are that he has a pin-rolling tremor on the right side, and there's also evidence of cogwheel rigidity on examination of his right arm and lead piping in his right arm. Both of these findings also show evidence of synkinesis, which exacerbates the cogwheel rigidity and lead piping. There is a much smaller amount of cogwheel rigidity and lead piping in examination of the left arm, which does also get worse with synkinesis. The patient didn't show any evidence of bradykinesia or gait instability, though there was evidence of micrographia on examination of his handwriting. There was also no evidence of any extrapyramidal signs, cerebellar signs, or gaze palsies on examination, which may lead to a diagnosis of a Parkinson's plus syndrome. I think the diagnosis in this case would be Parkinsonism, though I don't think I can give this gentleman a label of Parkinson's disease at present, as he doesn't have all of the classical signs of Parkinson's disease. These include tremor, rigidity, gait instability, and bradykinesia.
Can you describe the features of a Parkinsonian gait?
So the features of a Parkinsonian gait are a stooped posture, short shuffling steps from the bradykinesia, reduced arm swing, and because of the bradykinesia and postural instability, patients normally have difficulty turning, so it can be described as turning on block.
What are the causes of Parkinsonism?
So there are a number of causes of Parkinsonism. The first would be idiopathic Parkinson's disease. Patients can have drug-induced Parkinsonism. Wilson's disease can cause Parkinsonism. Also, normal pressure hydrocephalus can cause Parkinsonism. And there is also the Parkinson's plus syndromes. These are progressive supranuclear palsy, the multisystem atrophy syndromes, and also diffuse Lewy body disease.
What treatment options are available for Parkinson's disease?
So there are a number of treatment options available for Parkinson's disease, and it should be managed in a multidisciplinary team approach. Importantly, patients can require help from occupational therapists for any modifications that may be required in their home. They can also require help from physiotherapists with improvements to help improve their mobility, but also patients can have problems with their sleep and have difficulty in turning over at night, which can cause problems with insomnia and also can cause significant depression in patients when they are sleep deprived. Therefore, the physiotherapists can give patients different exercises to help them turn over in bed, which can improve their quality of life significantly. They also require help managing their mood, which can involve different forms of therapy and also antidepressant medication. There's also a number of medications which can be given to treat the Parkinson's disease itself. These are predominantly levodopa combined with peripheral decarboxylase inhibitors, dopamine agonists, and dopamine breakdown inhibitors.
Thank you.
Thank you.
Parkinson's disease is a neurodegenerative condition characterized by degeneration of substantia nigra dopaminergic neurons. On examination, classic signs of Parkinson's disease includes a resting tremor, rigidity, bradykinesia, and postural instability. The resting tremor is typically a pill-rolling tremor, usually affecting one hand. Rigidity. This is classically described as lead pipe rigidity, meaning there is increased tone throughout the range of passive movement and is best felt with passive flexion and extension of the arm at the elbow. Cogwheel rigidity refers to the combination of rigidity and tremor and can be demonstrated best by rotating the wrists. Rigidity can be increased by voluntary movements of the opposite arm, and this is known as synkinesis. Bradykinesia manifests in a variety of ways, including akinesia, which refers to difficulty in initiating movements, hypomimia, which refers to an expressionless, mask-like face, and a soft, low-volume, monotonous speech. On examination, bradykinesia can be demonstrated by asking the patient to make rapid opening and closing hand movements, or asking them to tap their thumb against opposing fingers as quickly as possible, with movements becoming slower and smaller with repetition. It can also be demonstrated in the characteristic Parkinsonian gait, where the patient has a simian-like posture, narrow base, and takes shuffling, hesitant steps with reduced arm swing. Finally, postural instability. There may be evidence of a tendency to fall backwards, retropulsion, or fall forwards, propulsion. This candidate assessed retropulsion, performed by standing a few steps behind the patient and pulling back on the shoulders. It is important to establish Parkinson's disease from Parkinsonism. Parkinsonism refers to the presence of bradykinesia and at least the presence of rigidity, tremor, and postural instability. A differentiating feature of Parkinsonism is the symmetrical distribution of signs. There are many causes of Parkinsonism, including neuroleptic medications such as metoclopramide, methyl-dopa, and sodium valproate, Wilson's disease, postencephalitis, and normal pressure hydrocephalus are other causes of Parkinsonism. Finally, there are the Parkinson plus syndromes. These refer to neurodegenerative conditions that have features of Parkinson's disease, but with an extra distinguishing feature, including pyramidal, cerebellar, and ocular signs. The most common form is progressive supranuclear palsy. Other causes include multisystem atrophy syndromes, which is characterized by varying features of Parkinsonism, cerebellar disease, pyramidal signs, and autonomic dysfunction. Therefore, as part of the examination, an excellent candidate would assess for cerebellar and pyramidal signs and assess for gaze palsy, which is what this candidate did. In addition, you should ask to undertake a lying and standing blood pressure, review the drug history, and assess cognition with a screening tool. Management in idiopathic Parkinson's disease should be holistic, geared towards the patient's individual needs, but may draw upon specialist input from neurologists, physiotherapists, occupational therapists, dietitian, and speech and language therapists, amongst others. With respect to pharmacological therapy for motor symptoms in Parkinson's disease, these include levodopa combined with a peripheral decarboxylase inhibitor to help reduce peripheral conversion of levodopa to dopamine, which helps to reduce side effects of nausea and vomiting. Other therapies include dopamine agonists and dopamine breakdown inhibitors, which include monoamine oxidase B inhibitors and catechol-O-methyl transferase inhibitors.
Hello there, is it Mr. Gallagher?
Mr. Gallagher, yes.
My name's Dr. Gavin Britton. I'm one of the medical doctors in clinic today. Can I start by asking how old you are?
I'm 49.
I've been asked to have a chat with you about breathlessness. Would that be okay?
Not a problem.
Can I start by asking you to tell me a bit more about that?
I just find it sometimes difficult when I'm walking. If I'm walking for, say, a distance or so, after, I'd say, 5 or 10 minutes, I start to get a bit breathless.
Okay. And when did you start to notice this?
About a few weeks ago.
Okay. Yeah. And before that, how were things?
All right, okay.
Okay. And over the last couple of weeks, do you think things are getting worse, or are they the same?
I think they're getting worse.
Okay. And in what way are they getting worse?
I just find it more difficult, to walk, further distance.
Okay.
Well, walking just, is a bit of a problem at the moment.
Fine, okay. And usually, how far could you walk?
Not a problem, just walk for miles.
So,
yeah.
Unrestricted?
Yeah.
And you wouldn't get breathless at any point?
No.
Okay. And just specifically, have you noticed anything else about this breathlessness or anything that comes with it?
Not really, no.
Okay. Have you noticed if you're breathless at night?
No.
And if you ever wake up during the night breathless?
No.
Can I ask how many pillows you use to sleep on?
Well, about, say, 2.
2. And has that changed recently at all? No. So that's the same?
Yeah.
Fine. Have you noticed a cough?
No.
Any symptoms of a cold, such as a runny nose or stuffiness of
Nothing
the face?
like that at all, no.
No, good. Any fevers?
No.
Any chest pain?
No.
Or any pain when you breathe in deeply?
Not much, really.
Not much. So have you had any, do you think, pain when you breathe in?
Not much, but it's caused me discomfort or anything.
Okay. Is that different to usual, or is that normal for you?
Normal.
Okay, fine. Have you noticed wheeze in your chest or a feeling of tightness?
No.
Good. And more specifically, have you noticed any problems with palpitations?
No.
Or dizziness or episodes of collapse?
No, definitely not, no.
Good. And just to go on to a bit more about your background, have you got any medical problems that you're aware of?
Got Marfan's.
Okay. And when was that diagnosed?
Say the last 2 or 3 years.
In the last 2 or 3 years? Okay, fine. And have you had any problems with your Marfan's?
Not really, no.
So no complications?
No complications, no.
Fine, okay. Ever had any operations or had to be admitted to hospital for anything?
Yeah, I've had an operation. I've had a valve fitted.
Okay. Do you know which valve that was?
Metallic valve.
Okay. So you've had a metallic valve. When was that?
About, say, 3 years when I discovered I had Marfan's.
So about 3 years ago. Okay, fine. And I presume, do you take medications for the metallic valve?
Yeah, I take warfarin.
Warfarin. And your warfarin levels, have they been within range in the last?
Yeah, I've been in range, yeah. Every time I've been, it's always been within range.
Fine, good. And do you have regular follow-up for your Marfan's?
We go to the hospital for a scan and then to see the consultant.
Okay.
See if everything still norm's not changed.
Okay. And what sort of scan is that?
It's a CT scan.
Okay. Do you know what they scan when they?
They scan virtually everything. Main fingers are like all the valves if it's still.
Okay.
Yeah.
Fine. And when was your last checkup?
6 months ago.
Okay. So that's reassuring, isn't
Yeah.
it? Then? That's good. Do you have any other medical problems?
No. Just sorry, I have mentioned high blood pressure.
Okay.
Yeah.
Fine. And other than the warfarin, do you take any other medications?
I just take high blood pressure tablets.
Do you know which ones they are?
Bifalstofalf or something, or Besamine or something, can't remember.
So
just take 2, yeah.
Okay, fine.
The Ciprol, that's it.
Bisoprolol,
yeah.
Okay. And another one as
Yeah.
well. Okay. Do you have any allergies?
Not that I know of, no.
Good, okay. Just to come on to a bit more about your home life, if I can. Who do you live with?
I live with my partner.
Your partner, okay. And you manage everything yourself usually?
We share it between us.
Fine. But you're normally independent? You don't need any help?
Yeah, don't need help for anything.
Good. Do you work?
I do, yes.
What do you do?
I work in the sales office.
Okay. And any previous exposure to any hazardous chemicals or asbestos or coal?
No, none at all.
Good. Do you smoke?
No.
Have you ever smoked?
No.
Good. Do you drink alcohol?
I do, yes.
How much, roughly, would you say you drank in a week?
I tend not to try and drink during the week, but weekends, depends how I feel. If I go out, I'll have, say, 3 or 4 pints.
Okay.
But from the house, I'll have, a bottle of wine, say, on a Saturday night, and a bottle of wine with dinner on a Sunday.
Fine. Okay. And is there anyone else ill at home at the minute? No. Nobody have any lung problems or breathing problems at home?
No.
And Anybody unwell with any medical problems in the family?
Well, my son's got Marfan's as well.
Okay. And has anybody in the family got lung problems or
No.
diseases such as tuberculosis?
No.
Or ever been exposed to anything, any other lung problems similar to that?
No.
Good. Just to touch on a couple more symptoms that you may or may not have had, if I may. Have you noticed any weight loss?
No.
Or changes in your appetite?
Still eat the same.
Still
Nothing yet. Still got any appetite.
Good. Any changes with your bowel function, such as constipation or diarrhea?
No.
Good. Any lumps or bumps, specifically in the neck or armpit or groin area that you've noticed?
No.
Good. Any night sweats or fevers?
No.
Any abdominal pain?
No.
And any changes with your urinary symptoms, urinary system, such as passing water more often, or pain when you urinate?
No.
Or any blood, either in the stool or urine?
No.
Good. What I'd like to do now, if that's okay with you, is have a look at you just up on the couch, and then we can have a bit of a chat about what we think is going on, if that's all right.
Yep, not a problem.
I'm just going to have a look at you from the end of the bed. Can I ask, have you noticed any swelling of the ankles?
Yeah, I've noticed when I go on holiday, when I'm being on a plane, my feet tend to swell up.
And have you been on any long haul flights recently?
Not recently, no.
Okay. And are your ankles swollen currently?
No.
Okay. And are there any joint aches or pains?
No.
Okay. I'll have a look at your hands, if I may. And if you turn them over and turn them back, just have a look at this finger. And could you do this for me and put both your fingers together? Thank you. I'll just have a feel of your pulses. Okay, and you can rest that one down. And if you turn your hands over, that's all right. Do you have any pain in the shoulder?
No.
Am I all right to lift this arm up?
Yeah.
Okay, that's fine. And if you rest your head back and turn it to the left. Do you have any pain in your abdomen?
No.
I'm just going to press on your abdomen. Okay, and you can relax. And if you peel one eyelid down, thank you, and open your mouth. And tongue up to the roof of your mouth. And relax, thank you. I'll just have a look at your chest now. If you put your hands on your hips. I'll have a feel of your chest now, you can relax. Okay. Have a listen to your heart. And a feel of your pulse. Can you lean over towards the left-hand side, please? Okay. relax. If you breathe in and out and hold it out and relax, that's okay, breathe away. And if you sit forward, breathe in and out and hold it out. And breathe away. And we'll do that one more time. Ready? And out and hold it out. And relax, that's okay. And if you sit forward now and have a look at your back. I can see you've got another scar here on the back. What's that from?
I had an operation about a year and a half ago for my aorta.
Okay, okay. And do you currently have any back pain at all?
No.
I'm going to put my hands on your back now. I'd just like you to breathe in and out deeply. And once more. Thank you. I'll have a feel of your lymph nodes in your neck now. And the other side. I'm going to tap over your back now.
Mm.
And I'll have a listen. So if you can just breathe in and out every time you feel the stethoscope touch your chest. And I press on the bottom of your back. And I'll have a look at your ankles. Are you able to lift your trousers up? Thank you. Thank you. Can I ask, is there anything that concerns you?
My breathlessness, which may be related to my mouth hands.
I can understand how that must be one of your worries, especially given the operations you've had in the past related to your marfans. What I'd like to do to reassure you today is perform a few investigations from this clinic and see you back in a few hours with the results of those investigations. Hopefully we'll be able to go some way into establishing the cause of your breathlessness,
Yeah.
and that should hopefully reassure you as well. Would that be okay with you?
Not a problem.
Okay. To complete my examination, I'd like to check for any radiofemoral delay and request a full set of observations.
Would you like to summarise this case for me?
This middle-aged gentleman presented with a subacute onset of breathlessness with an absence of any infective symptoms. This is on a background of marfans. The cardiorespiratory examination was evident for a midline stenotomy scar and a metallic click heard over the second heart sound, which I feel may represent an aortic valve replacement. As well as this, there was also an early diastolic murmur, which was in association with a mild collapsing pulse. Whilst there was early signs of clubbing, Shamroth's test was negative, and there were no other features of infective endocarditis. Other important negatives were an absence of any sign of fluid overload, and I feel that this patient was euvolemic. To summarise the case, I feel that there may be a degree of aortic valve incompetence in regards to his replaced valve, and this may be resulting in his breathlessness.
Did you hear any other cardiac murmurs apart from the early diastolic murmur?
On auscultation, I did also appreciate a systolic murmur. However, I feel this is more of a flow murmur and is therefore not pathological.
Are you aware of any other systolic murmurs that can be heard in patients with Marfan syndrome?
Patients with Marfan's can also have mitral valve prolapse as well as mitral regurgitation. However, I didn't appreciate either of those here.
What would be in your other differential diagnoses for this gentleman's breathlessness?
Whilst there are a variety of other differentials, the most important ones to consider here would be a resolving pneumothorax, infective endocarditis, pulmonary edema, which I didn't appreciate in this case, and also a pulmonary embolism. However, I understand this patient was appropriately warfarinized.
How would you investigate this gentleman?
So I'd want to start off with some baseline blood tests, starting off with a full blood count looking for any signs of anemia, as well as inflammatory markers looking for any sign of infection. I'd want some baseline urea and electrolytes, as well as liver function tests and a coagulation screen just to ensure that he is appropriately warfarinized. After this, I'd want an ECG, looking for any evidence of ischemic heart disease, and I'd go on to performing an echocardiogram, looking to confirm that suspected valvular incompetence. Following this, I'd want to request a chest x-ray, just screening for any respiratory differentials, including that potential pneumothorax. And lastly, I could consider pulmonary function tests, but I don't think they're indicated as a first-line investigation at this stage.
This gentleman had a median stenotomy scar, and you mentioned he's had an aortic valve replacement. Could he have had a coronary artery bypass graft at the same time?
He may well have done, but whilst I didn't appreciate a vein harvest graft in the great saphenous vein distribution in the lower limbs, I do realise he could have had a harvest from the left internal mammary vein.
And what features of Marfan syndrome did you see in this gentleman?
So whilst examining him, I did appreciate a high arched palate, a disproportionately long arm span in relation to his height, arachnodactyly and flat feet.
Are there any features that you could demonstrate to the examiner that he had Marfan syndrome?
So there is the wrist sign and the thumb sign I could have asked the patient to demonstrate.
Can you explain those to me?
So the wrist sign is positive when the thumb and fifth digit of one hand overlaps when placed over the wrist of the other arm. The thumb sign is positive where the distal phalanx of the adducted thumb during a closed fist protrudes beyond the ulnar border of that hand.
You mentioned this gentleman was clubbed. What is the significance of that here?
So clubbing may be seen in subacute infective endocarditis as well as in malignancy. However, I don't think that's relevant to this case as there were no other features of either of these two differentials.
Do you know of any eye complications of Marfan syndrome?
Patients can have an inferior lens subluxation, which is also known as ectopia lentis.
Thank you.
Thank you.
The presenting problem is of a relatively short history of progressive exertional breathlessness over a few weeks, which obviously has a wide differential diagnosis. These will be mainly related to the cardiorespiratory system, but don't forget anemia can present with shortness of breath. A focused history exploring all the possible causes for breathlessness was done very well in the history of presenting complaint. There was no obvious definitive cause identified following the initial history. This patient has evidence of an aortic metallic valve, together with a major thoracoabdominal scar, indicating surgery for repair of a probable thoracoabdominal aortic aneurysm as a complication of his Marfan syndrome. Both these surgeries were relatively recent in the last few years. The presence of clubbing and a replacement valve raises the possibility of subacute bacterial endocarditis, but lung cancer in the setting of someone presenting with breathlessness should also be considered, even in a non-smoker. There is evidence of a systolic murmur relating to his metallic valve, which is most likely due to normal flow across the valve. However, the early diastolic murmur, immediately after the metallic second heart sound, points towards valvular incompetence, which would be more worrisome. It must be remembered that mitral valve regurgitation and mitral valve prolapse occur in Marfan syndrome and would need to be excluded here. The investigations mentioned in this case are all appropriate, with the echocardiogram being the most important for demonstrating prosthetic valve integrity if both bloods, chest X-ray and ECG were normal. Further investigations, if no diagnosis has been made, could include a peak flow measurement or spirometry, or even a CTPA. Again, if normal, further cardiac tests, such as a stress echo or myocardial perfusion scan, may be considered. This gentleman stated he has Marfan syndrome, so the focus of the history and examination was on trying to diagnose the cause of his current problem, with Marfans in mind, rather than demonstrating the features of his Marfans to the examiner. These features for interest are his tall stature, long arm span, high arched palate, arachnodactyly, and flat feet. He did not have a scoliosis or any abnormality of his thoracic cage, such as pectus excavatum or carinatum. If this station was related to the diagnosis of Marfans, then the wrist and the thumb sign could also be demonstrated. The wrist sign is when the thumb and little finger overlap when grasping the wrist of the opposite hand. A positive thumb sign means that the distal phalanx of the adducted thumb extends beyond the ulnar border of the palm.
Good morning.
Good morning.
My name's Dr. Farrant. Can I just confirm your name, please?
Yes, it's Mr. Wayne Jones.
Nice to meet you, Mr. Jones. I understand you've been having some problems with pain in your abdomen, is that correct?
Yes.
Can you just tell me a little bit more about it?
Yeah, the pain's constant and it's in me. If you would say that right in the centre, like where, you know, ability trees, that type of stuff, you know.
Yeah, okay. And how long have you had the pain for?
Many years. And it's just constant.
Okay.
Literally constant.
And does the pain go anywhere, or does it just stay right in the centre?
No, it's in the centre, but sometimes it goes through to the back.
Through to your back?
Yes.
Okay. Anything make it better or worse?
Not really. I have to take paracetamol or, you know, sometimes something stronger.
Okay.
Just try and get rid of it. And lie down basically, but I can't. If I eat, I get pain. You know, if I drink too fast, I get pain.
Okay.
You know.
And is it that case with all sorts of food, or
yes?
So there's nothing in particular that would set it
No, I
off?
tried different types of food. I tried cutting out spicy. I tried cutting out, you know, meats and stuff like that. But it's always the same.
Okay. And do you get any sickness at all? Any nausea?
Not often, but I used to do quite a lot, but not often at the moment.
Okay. And any change in your bowel habits at all?
Plenty. I have
Okay.
to take laxatives most days.
Okay, because you get constipated a
I
lot.
do, yes. I seem to get bloated with it.
Okay. And do you feel as though your abdomen swells at all? Or
Yes.
It does swell?
Yes.
Okay. And any change in your waterworks at all?
No, not at all. I have had a couple of water infections because, you know, I've not drank enough or whatever. But no, on the norm, no. Other than that, I've only had a couple.
Okay. And do you have any past medical history at all? Any medical problems that you see the doctor for regularly?
Yes.
Okay. Do you want to tell me a bit more about them?
Yes. I've got this thing called Corollas.
Corollas disease?
Yes.
Okay. Do you want to tell me a bit more about Corollas disease?
Yeah, Corollas is a cystotic disease.
Okay.
And it
attacks your liver?
Yes, it does.
Okay. And what problems have you had with your liver as a result of this Corollas disease?
Problem was it was swelling. It was the pain. The pain was phenomenal with it. I mean, really bad.
Okay.
It was that bad. I was on morphine for quite a while.
Oh, gosh. Okay.
And then, you know, it just ended up being in hospital.
Okay. And did you need any procedures on your liver at all as a result of the cysts that developed from this condition? Okay. Do you want to tell me a little bit about the operations that you've had?
Yes, and I had a liver resection.
Okay.
And then 2 years after, took 2/3 of my liver away, as you understand.
Okay.
And then 2 years after, when it grew back, it grew back solid with the Corollas still in it.
Oh, gosh, okay.
So therefore, I had to have a liver transplant.
Right, okay. And how many years ago was that?
That was 1998, which is 20
odd years ago.
20 odd years ago, yes.
So you've had a transplant for a long period of time?
I am, yes.
And did you have any complications in relation to the transplant at the time of having the operation?
Not really. I recovered quite well with the transplant. It was like instant. Even my wife says, when I was in intensive care and I opened my eyes was white for the first time in 4 years.
Really?
Yes, because I was jaundiced all the time. And it was instant. The recovery was instant. Then it's just the pain you got to deal with.
Okay.
But the recovery from my liver was instant.
Good. And what medications have you been taking as a result of having this transplant?
At first, I was taking cyclosporin as an anti-rejection tablet.
Yep.
I was on that from 98 till 2006.
Okay.
And since 2006, I've been taking microphenolate, MMF, and prednisolone.
And what led to the change from the cyclosporin to the mycophenolate?
The cyclosporin, they said I was on it too long and it caused non-Hodgkin's lymphoma in my neck.
Oh gosh, okay.
I ended up I had 5 lumps in my neck. So I had 4 removed by surgery and I had to have 1 removed by chemo.
Okay. And any other problems in relation to the medication that you've been taking? Do you get bruising of your hands at all?
It's total bruising all the time. Anything touches me, I bruise, and my skin's gone like paper. But that is me prednisolone, it's my steroids.
Okay.
They've said it's my steroids, and there's nothing anybody can do about it really because I need them.
Obviously, that's quite a big, condition and operation to have had.
Yes.
How has that affected you on a day-to-day basis?
At first, it affected me quite a lot. Mentally, I wanted to cuddle it and hold it and protect it. But then I realised that I've got to get back on with my normal life. So I went back to work when I was fit enough.
Good.
I've had a brilliant working life since 1998 till 2020.
Great.
I retired in 2020 due to ill health because of other reasons.
Okay. So actually you've been able to sort of go about normal tasks of daily living and
Absolutely.
work for the whole time with this transplant?
Yes, I'm still in pain every day, but the pain gets less. It sounds silly, but you do get used to it. And if you can, instead of taking morphine, you can just take a paracetamol.
Okay.
But you can't take too many because it's a liver transplant.
Okay. And do you smoke at all?
I do, yes.
How many cigarettes do you smoke a day?
I'd say between 15 and 20.
And have you done that for a long period of time?
Since I was a teenager.
Since you were a teenager. Okay. And do you drink at all?
Very rarely.
And
Very rarely. That- Special occasion.
Okay. And who's at home with you normally?
My wife.
Okay. And is she okay looking after you? Does she need to do much for you?
She does, yes. Yes, when I'm poorly, she really has to do a lot for me.
Okay.
You know, because when I'm in that much pain, I can't even bend down to put my socks on, you know, anymore. But, you know, yes, she does look after me.
Okay. And are you allergic to anything?
Ranitidine.
You're allergic to ranitidine?
Yes.
What happens if you take ranitidine?
Apparently, I was in intensive care and they put a bit of ranitidine into me in my vein, and I was asleep and I went grey and started vomiting.
Right.
So
okay.
obviously they stopped.
So a strong reaction to
Yes.
it. And is there any family history of this condition at all?
None at all. None whatsoever.
And no other conditions that run in your family?
No.
Okay. Fine. So I think the best thing to do now, if possible, would be for me to try and examine you, if that's okay.
Absolutely.
Fantastic. Thank you.
Thank you.
Okay, sir. So if it's okay with you, I'm going to examine you now, if that's all right.
Absolutely.
Thank you. Okay, so can I just get you to take a nice deep breath in for me, please? And out. Give me a cough. And if you just raise your arms above your head for me, please. And back down. Thank you. Can I have a look at your hands, please?
Certainly.
And turn them over for me, please. Just relax that hand down. I'm just going to feel your pulse. Okay. And then just hold your hands straight out in front of you, nice and still. And then cock your wrists back, hold them there. Okay, you can relax that hand down. I'm just going to have a look at your finger now. Okay, that's great. Just going to have a look in your armpits, if I may, and have a quick feel. Okay, and relax. Now I'm just going to have a look at your eyes. If you wouldn't mind pulling down on one of your eyelids for me, please. And look up. That's great. Now if I could have a look in your mouth, please. Could you open your mouth for me? Just going to shine a light in. And if you just pull down on your gum for me, please. Thank you. I'm just going to have a feel of the pulse in your neck now, if I may, okay?
Yes.
Okay, I'd now like you to look over to that side for me, please, and just relax. I'm just going to have a press on your abdomen. Okay, and look forward for me, please. Okay, I'm just going to have a feel above your neck. Okay. And you mentioned that you'd had surgery on the right hand side of your neck to remove some lymph nodes from the non-Hodgkin's lymphoma. So I'm just going to have a look at the scar there first of all. Okay. So if you wouldn't mind just sitting forward for me, please. Okay, I'm just going to have a feel of your neck now. Okay, and relax back for me. So I'm just going to have a look at your chest now, okay?
Okay.
Okay. I'm just going to have a look at your abdomen now.
I'm now going to lower the bed down, okay?
Yes.
I'm just going to have a feel of your abdomen now, okay? Just stay nice and relaxed and let me know if it's tender at all. Deep breath in for me, and out. And again, and out, and again, and out, and again, and out. Okay. Deep breath in for me, and out, and again, and out, and again, and out, and one more, and out. That's great. Okay. And just roll towards me slightly, and back down, and away from me, and back down. Okay, I'm going to have a tap on your abdomen now, if that's okay. I'm just going to tap on your abdomen now. Okay. And if you just roll away from me and relax. And back. Okay. I'm just going to have a quick listen to you now. And now I'm going to have a look at your legs. Okay. So to complete my examination, I would like to examine the external hernial orifices and do a digital rectal examination to assess for rectal varices. So sir, have you got anything that's concerning you particularly today?
Yes, the pain issue.
Okay. So there are a few tests that I would like to do to try and ascertain the cause of the pain that you've been suffering with. So I'd like to do a full set of bloods, particularly doing something called a full blood count to check your kidney function with something called a Usinase, check your liver function, check the clotting to make sure your blood's clotting appropriately, and also check something called an amylase. And then I'd like to do some further imaging investigations in the form of either an ultrasound scan or a CT scan to look at things in a bit more detail, and then we'll have a further chat. Okay?
Lovely, thank you.
Thank you. This completes my examination. Thank you.
Please can you present your findings?
So this patient presents with generalised abdominal pain, which is central and occasionally radiates to the back. Symptoms are generally made worse when eating foods, though there are no specific foods which do trigger the pain. He also reports a history of Caroli's disease, which he appears to have had for over 20 years and has caused numerous problems. In particular, he has had to have multiple surgeries on his abdomen, including a liver transplant. There are multiple signs of these abdominal surgeries when looking at this gentleman's abdomen, with a Mercedes-Benz incision and also multiple midline laparotomy scars. The midline laparotomy scars appear to have undergone revision with potential wound dehiscence, and there is also sign of complications of his immunosuppressive therapy in the lymph node biopsies and resections that he's had in his neck as a result of non-Hodgkin's lymphoma. Focusing on the transplant, I believe that his transplant is currently working well, as there are no signs of active liver disease. He is not showing signs of jaundice, there is no ascites, and there's no obvious signs of portal hypertension.
Okay. Can you give me some differentials for a liver transplant?
So the most common cause of liver transplant would be liver cirrhosis, and causes of liver cirrhosis are autoimmune hepatitis, non-alcoholic fatty liver disease, alcoholic liver disease, and then there are also acute causes of liver failure, the most common cause in the UK being a paracetamol overdose or an acute viral hepatitis.
Can you give me a few complications of immunosuppression medication?
So the complications from immunosuppressant medication are numerous, and first of all, looking at the steroid medication that patients can be on, steroids can cause thinning of the skin, easy bruising, weight gain, hypertension, and cataracts. The second set of medication would be cyclosporin, which can cause gum hypertrophy, hypertension, and can also cause an increased risk of cancers, which I believe this gentleman has suffered from, as he reported multiple neck lymph nodes, which were found to be non-Hodgkin's lymphoma and had led to him having a resection with evidence of a scar at his neck.
Thank you. You mentioned that you felt that the transplant was working well. What would you find if you didn't think it was working well?
So if it wasn't working well, there would be signs of liver disease. First of all, the patient would be jaundiced with yellowing of the sclera and of the skin. There would also potentially be signs of ascites, so positive shifting dullness. And I would also look to see signs of varices, with caput medusa in the abdomen, and if I did a digital rectal examination, there would potentially be rectal varices also.
And how might you select out which patients might best benefit from a liver transplant?
So the decision to refer someone for a liver transplant should be made by a multidisciplinary team. The MDT should select patients who have significant signs of liver disease, and also based on their potential prognosis following a liver transplant. There are numerous scoring systems we can use for assessing someone's prognosis, but the most common one is the UK end-stage liver disease model for the prediction of prognosis.
Thank you.
Thank you.
This is clearly a very complex case handled very well by a competent candidate. There is a lot of information in the history, and the skill is to focus on the main issue, which is the liver transplant. Constant abdominal pain is the patient's main concern, which is addressed well by the candidate. A good candidate continues to talk to the patient during the examination, keeping a good rapport, and can clarify any of the history, or indeed certain findings may lead to further questioning and new lines of inquiry. This is perfectly valid and demonstrates how a true consultation may occur. The candidate summarised the patient's concerns at the end and agreed to an action plan going forward. Liver transplant should be immediately considered as soon as you note the classic bilateral rooftop with sternal extension scar, often termed a Mercedes-Benz scar, or the J-shaped scar, which is called a Makuchi incision. Once you have noted a scar suggestive of transplantation, you should start to think of all the potential important positive and negative examination findings you may see in the context of a liver transplant. The key points you need to try and get across to the examiner is firstly that you recognise the scar and that the diagnosis is a liver transplant. Secondly, you need to state whether you think the transplant is functioning adequately and what leads to that opinion. Thirdly, you should comment on any notable side effects from immunosuppression. And lastly, you should comment on whether there is any evidence to the underlying etiology of the native liver disease, and if not, offer a sensible differential for this. To know whether the transplant is adequately functioning, you need to think about whether there are signs of chronic liver disease, whilst bearing in mind that some signs of chronic liver disease, such as Dupuytren's contracture and gynecomastia, may persist post-transplantation. You need to think about whether you have detected evidence of portal hypertension, such as caput medusa and splenomegaly. But again, you must bear in mind that whilst portal hypertension will likely improve post-transplantation, if a patient has severe splenomegaly pre-transplant, their spleen may remain enlarged post-transplantation. Importantly, you should take note and state whether there are any signs of hepatic decompensation. Asterisks or ascites, if present, are strongly suggestive of an inadequate graft function. Jaundice may also be an indicator of graft dysfunction, particularly if other signs of decompensation are noted. In the case of this patient, he had a scar of a liver transplant and slight palmarothema, but no other evidence of chronic liver disease related to his transplant. He had no evidence of portal hypertension and did not have ascites. His liver transplant appeared to be working well. The transplant itself may or may not be palpable. If a transplanted liver is easily palpable, it does not necessarily mean that there is a problem with the graft and could simply reflect a size mismatch between the donor and recipient. With regards to side effects of immunosuppression, it would be helpful to comment on presence or abscess of skin lesions such as seborrheic warts, actinic keratoses, or scars from resections of skin malignancies. In particular, make sure you have checked sun-exposed areas carefully for scars such as the face, scalp if there's hair thinning, top of the ears, upper chest and shins. Steroid side effects may include evidence of diabetes with finger prick marks from glucose monitoring or bruising to the abdomen from insulin injections. Unless transplanted recently, it is unlikely that the patient will be grossly Cushingoid. Tremor may indicate tacrolimus toxicity. Gum hypertrophy from cyclosporin toxicity is often commented on, but it's rarely seen now. It is unlikely that you'll be able to detect the underlying liver disease from examining the patient, but take note and mention presence of scar from venesection, which indicates an underlying diagnosis of hemochromatosis, tattoos which could suggest a chronic viral hepatitis, or significant xanthelasma which could suggest primary biliary cirrhosis, which is now known as primary biliary cholangitis. Also look out for scars consistent with previous tracheostomy insertion, post-operative drain scars, and scars from previous ascitic drains. Picking up and mentioning these less obvious scars is likely to impress the examiners. If there is no evidence of underlying cause of native liver failure, then let the examiner know that you are aware of the commonest indications for liver transplantation in the UK: cirrhosis, hepatocellular carcinoma, and acute fulminant liver failure. Cirrhosis may be due to a large number of conditions, including, but not limited to, alcoholic liver disease, non-alcoholic fatty liver disease, autoimmune liver diseases, hemochromatosis, Wilson's disease, or alpha-1 antitrypsin deficiency. Acute liver failure is defined as a multi-system disorder in which severe acute impairment liver function with encephalopathy occurs within 8 weeks of the onset of symptoms and no recognised underlying chronic liver disease. There are also a number of so-called variant syndromes which may lead to listing for transplantation. Variant syndromes include diuretic-resistant ascites, chronic hepatic encephalopathy, intractable pruritus, hepatopulmonary syndrome, polycystic liver disease, and recurrent cholangitis. Prior to listing for transplantation, patients are assessed and reviewed by a specialist MDT. Contraindications to transplantation include intravenous drug abuse, ongoing alcohol excess, particularly in patients with ALD where abstinence is mandatory, significant medical or psychiatric comorbidities if they would be likely to affect survival post-transplant, such as cardio or cerebrovascular disease. Age alone is not a contraindication, although survival in the over 65s is significantly worse than younger patients. Any history of prior malignancy would be strongly considered by the MDT, particularly if the risk of recurrence is high. Patients can be listed for either an elective or a super urgent transplant. Patients can be selected for an elective liver transplant if they meet certain criteria. If they have chronic liver disease or failure and have a high UK end-stage liver disease, abbreviated to UK-ELD, score of 49 or more. This score is derived from the patient's serum sodium, creatinine, bilirubin, and the International Normalised Ratio, or INR. Patients with portopulmonary hypertension should have a clinically significant response to long-acting prostacyclin or analogues, sildenafil or bosentan. Lastly, patients with severe acute alcoholic hepatitis may be considered for electrode transplantation if their expected survival in the absence of transplantation is less than that obtained with a liver transplant. Maddrey and Glasgow alcoholic hepatitis scores can be used to predict prognosis. All patients selected for an elective adult transplant list must have a projected post-transplant 5-year survival of more than 50%. For patients with hepatocellular carcinoma, in order to be eligible for elective transplantation, there are strict criteria which must be met, including number and diameter of tumours and rate of progression. Clearly, a patient must have no extrahepatic spread. For patients with a variant syndrome and a UK ELD score of less than 49, there are set criteria. For example, for diuretic-resistant ascites patients, they must be intolerant of maximum diuretic dosage and not responsive to TIPS, or TIPS is unable to be performed. Super urgent transplantation listing has a separate strict set of criteria that must be met. For example, in acute paracetamol poisoning, patients with a pH of less than 7.25, 24 hours after overdose and after fluid resuscitation, or patients with a PT of more than 100 seconds, or INR more than 6.5, and serum creatinine more than 300, or anuric, and grade 3 to 4 encephalopathy would meet the criteria for super urgent listing. Following transplants, patients must be immunosuppressed. Steroids are used initially but are aimed to be weaned down to a small maintenance dose or weaned off completely. Calcineurin inhibitors given with tacrolimus being most commonly used. Other drugs such as azathioprine or mycophenolate may also be used, and protocols for immunosuppression will differ between centres. Generally, once patients achieve adequate liver function and are free of rejection for 6 months, they can often be managed with a single agent, typically a calcineurin inhibitor. Survival post-transplant is generally quite good. Almost 90% of patients will be alive at 1 year and 3/4 at 5 years. Complications from transplant include episodes of rejection, particularly in the early post-transplant phase. Immunosuppression leads to increased risk of infection, which can be viral, bacterial, or fungal. Immunosuppression also increases the risk of malignancies, especially skin and post-transplant lymphoproliferative disorders. Patients commonly develop a metabolic syndrome with hypertension, insulin resistance or diabetes, dyslipidemia and obesity. Patients must be advised to avoid live vaccines. Acute and chronic kidney disease is common in liver transplant recipients, and it is caused by a multitude of factors, including calcineurin inhibitors, diabetes and hypertension. Hepatobiliary complications include acute or chronic rejection. Biliary complications include leaks and strictures. Recurrence of primary liver disease may also occur in some cases, such as viral hepatitis, primary biliary cirrhosis and Budd-Chiari syndrome. In the exam, you are most likely to be questioned on conditions that may require liver transplantation and how to investigate for them, criteria for liver transplantation, immunosuppression, and complications following transplantation.
Okay, so actually, I am impressed by our colleagues who stayed with me for the whole day. So whoever is there, thank you very much for withstanding all this time. And I know we are all busy. We have our obligations and our work. So whoever is there, thank you for being with me. And I hope, inshallah, now we have finished during this long day revision. We have finished 26 cases, and the good thing that those cases are variable. you will find the neurological cases, chest cases, endocrinological. You will find cardiological cases, abdominal. All cases were covered in this regarding the history taking and regarding the clinical examination. So this is a comprehensive review of medicine. Whatever there are some comments or some things that should be corrected or added, but anyway, a lot of information, and this information is very valuable for the exam and for practice. And if you spend this day looking for these videos, you will be a good doctor and you'll be able to go for the exam even you didn't have enough time to revise everything. So if any questions, please unmute and ask. And I am impressed by all this list of doctors who stayed with me. Some may come later on, but some stayed with me the whole day. So if any comment or any question, please unmute and tell.
Sarah, thank you very much. You stayed the whole day with us, answering all our questions humbly. You are the best. Thank you. Jazakallah khair.
Thank
Today
you.
I
Yes,
learned
it.
to
Yes.
my information. I think now I'm in another level. Thank you. This is because of you. Jazakallah khair.
I appreciate, and this is very precious to me, and this give me huge compensation for all the time and the effort. And I hope, inshallah, this will be useful for you in your life and in your practice and in your exam. And we'll go through all other parts of medicine and videos, inshallah, bismillah, during this period. So I hope, inshallah, you join us, and we'll announce whenever there is a meeting or there is a revision, and we hope the benefit most for all of you, inshallah. Any other comments or any other feedback or any other? Okay, Dr. Hala, thank you very much. I appreciate your time and also being with me, and inshallah I will share the recordings whenever I receive. I will share in the group. Thank you for all of you, and I hope the best of luck in the exam and in your life, and inshallah meet again very soon.